Hello. Hello, ladies and gentlemen. Good afternoon. It's our honor to be your host in the brilliant lecturer and audience of this webinar. I'm Dr. Rayhana Hosseini from Tehran University of Medical Science, the moderator of the webinar. Thank you all for joining us in this webinar. I'd like to appreciate the efforts of the executive team of Tehran University of Medical Science, especially Dr. Jalaifa, and the kind acceptance of the lecturer for speaking. In the last decades, laparoscopy has been progressively introduced in the management of gynecologic cancers to evaluate tumor resectability, avoiding and explorative laparotomy, to identifying non-responders, to submit to second-line chemotherapy, and to perform primary or secondary minimally invasive debulking in selected patients. There are also some concerns. We would like to discuss these debates in this webinar. Our first lecturer is Dr. Firuza Hashemi from Khatam Hospital, consultant in gynecologic oncology surgery, and she is a perfect doctor in the field of laparoscopic oncology. Dr. Firuza Hashemi, we are ready to hear your speech about endometrial cancer and laparoscopic surgery in endometrial cancer. Dr. Firuza Hashemi. Dr. Firuza Hashemi, we are ready to hear a speech.
Okay, hello dear doctors. Can you hear me?
Yes, we can hear you.
Okay. I'm so delighted to be here with you, and I found this the best opportunity to present and share my lecture with you, dear colleagues. The topic of my lecture is laparoscopy in endometrial cancer. During my lecture, I will try to answer these 5 questions. What is the evidence in minimally invasive regarding minimally invasive surgery in endometrial cancer? Is it oncologically safe to do laparoscopy in endometrial cancer? What are the specific complications by doing laparoscopy in endometrial cancer? Is obesity considered to be a limiting factor? Is old age a limiting factor? And last but not least, are there any other limiting factors for minimally invasive surgery? Treatment goals in endometrial cancer. My first question concerns treatment goals in endometrial cancer. I mean, what are the treatment goals in endometrial cancer? The main goal is curing the cancer, first of all, by removing tumor and then staging disease to find prognostic factors to determine if the patient needs further adjuvant treatment or not. Surgical treatment in endometrial cancer includes total hysterectomy plus bilateral salpingo-oophorectomy, and in some cases, a specific pathology such as serous type, we should do omentectomy too. But regarding pelvic and parotid lymph node dissection, there is no any certain data rules, and and there are lots of controversial issues in this area. Surgical treatment in endometrial cancer can be done by laparotomy or laparoscopy or robotic surgery, or even in the cases that there is no need to remove lymphatic tissues, we can do it by vaginal route. History of minimally invasive surgery in endometrial cancer dates back to almost 2 decades ago. The first laparoscopic hysterectomy in endometrial cancer was done in 1989, and the first laparoscopic extraperitoneal aortic lymph node dissection was done in 2000, and the first robotic surgery in endometrial cancer was done in 2005. John Walker has performed an amazing research to compare laparoscopy and laparotomy for comprehensive surgical staging in endometrial cancer. This study is known as LAP2 trial, and the final result of this study has been published in 2009. Women in the laparoscopic group had similar rate of intraoperative complications and longer operation time, but fewer moderate to severe postoperative adverse events. Regarding hospital stay, the laparoscopic group had 2 days fewer than laparotomic group. There was no difference between groups in the rate of detection of advanced stage disease. In this slide, I put emphasis on short-term effects of doing minimally invasive surgery in endometrial cancer. There was no difference in intraoperative complications, and there was significant advantage of laparoscopy over laparotomy in terms of postoperative complications. There was less estimated blood loss and hemoglobin changes after laparoscopy, and the operative time was not consistent with higher with laparoscopy. One concern regarding the LAP2 trial was the conversion rate. It was about 26%, and only 4% were converted due to advanced disease. The another cause for lapar conversion was high body mass index, especially more than 40. It should be noted at the time of the LAP2 trial, many surgeons were relatively new to minimally invasive surgery for endometrial cancer in staging. Regarding long-term effects, according to LAP2 trial, minimally invasive surgery was oncologically safe with the similar overall survival and progression-free survival in comparison with laparotomy. Another randomized clinical trial was done by Monica Janda in 2017, and effect of total laparoscopic hysterectomy versus total abdominal hysterectomy and disease-free survival among women with stage 1 endometrial cancer was evaluated. This randomized clinical trial is known as LACE trial, and it was a multinational randomized clinical trial conducted 2005 and 2010 by 27 surgeons from 20 cancer centers, and follow-up of this study ended in 2016. According to this study, again, it is approved that minimally invasive surgery is oncologically safe in endometrial cancer with the same overall survival and progression-free survival. And quality of life has been improved up to 6 months after the surgery. A Cochrane review study was done in 2012, and it included 8 randomized clinical trials and consisted of LAP2 trial 2, and they confirmed there was no difference in the risk of death or recurrence between 2 groups. After publishing LACE trial in 2018, that previous Cochrane study was updated. It included 9 randomized clinical trials and consisted of LAP2 and LACE trial, both of them. And they suggested, the final results suggested that There was no clinical difference in the risk of severe postoperative complications in women in the laparoscopy and the laparotomy, and there was no significant difference in the risk of death between two groups. Additionally, laparoscopy was associated with a significantly shorter hospital stay. Ultimately, they decided that for presumed early stage primary endometrioid adenocarcinoma of the endometrium, laparoscopy is associated with a similar overall survival and progression-free survival. And in 2020, European Society of Gynecological Oncology, according to these two trials, I mean LAP2 trial and LACE trial, excuse me, I cannot go continue. And they suggested minimally invasive surgery as a preferred approach in endometrial cancer, in early stage endometrial cancer, even in the high-risk group. But we should respect to the oncologic rules to avoid any intraperitoneal tumor spillage, including tumor rupture or morcellation. If vaginal extraction risks uterine rupture, other measures should be taken, including such as mini laparotomy or use of endovascular. Tumors with metastases outside the uterus and cervix are relative contraindications for minimally invasive surgery. But what does National Cancer Comprehensive Network say in 2021 regarding minimally invasive surgery in endometrial cancer? It says whenever the disease is limited to the uterus, minimally invasive surgery is the preferred approach for these cases because of a lower rate of surgical site infection, transfusion, DVT, decreased hospital stay, and lower cost of care without compromise in oncologic outcome. Another part of my talk is about specific complications regarding minimally invasive surgery in endometrial cancer. One of them is port site metastasis. According to Zivanovic study, it was about 1 in 400 cases, and overall incidence was less than 0.5%, and the incidence of isolated port site metastasis was 0. Another specific complication of minimally invasive surgery is related to peritoneal seeding. A theoretical pitfall for doing laparoscopy in endometrial cancer is the retrograde seeding with the use of a uterine manipulator. On this basis, some surgeons, before starting surgery, before starting hysterectomy, they seal both fallopian tubes. But according to Eltobach study in 2006, if the incidence of positive peritoneal cytology is higher after laparoscopic surgery is controversial. Based on Lyme study in 2008, the presence of isolated endometrial cancer cells in peritoneal cavity is not associated with a higher risk of recurrence. I mean, it is not an important issue. Is obesity a limiting factor? According to Martinek systematic review in 2010, laparoscopy is the preferred approach in these cases due to decreased wound infection and hospital stay. Another question is about old age. Is old age a limiting factor? As you know, by 2030, 20% of population is more than 65 years old, and endometrial cancer is the most common genital malignancy among women. A retrospective analysis from LAP2 trial was done by Bishop in 2017, and they found 1,477 cases were over 60 years old. And the result showed there was a direct relationship between age and maximum toxicity for each treatment group, as you can see in this figure. In laparotomy group, there was higher postoperative complications such as antibiotic administration, ileus, pneumonia, DVT, and arrhythmia. And they concluded geriatric patients should not be deprived of standard surgical treatment because of their associated age risk. And laparoscopy should be the preferred approach in this group, but it needs an expert anesthesiology team. And the last part of my talk is about other limiting factors in minimally invasive surgery. One of them is uterine size, bulky or macroscopic extrauterine disease, and in type 2 endometrial cancer. As you know, we are not sure about the outcome of the surgery by minimally invasive surgery in type 2 endometrial cancer. Another limiting factor is related to medical factors such as high intracranial pressure, pulmonary arterial hypertension, and the last but not least one is an unexperienced surgeon to do laparoscopic surgery. In conclusion, I should summarize that minimally invasive surgery is the gold standard supported by overwhelming evidence. Any indication for laparotomy must be documented. Minimally invasive surgery is oncologically safe in the earliest stage of endometrioid, endometrial adenocarcinoma. Quality of life has been improved during the first 6 months. Blood loss is decreased, post-operative complications are reduced, and it is the preferred approach in obese and old patients. Thanks for listening to my lecture. I would like to show you my surgery. It is related to laparoscopy in endometrial cancer, pelvic lymphadenectomy. I want to show you. Would you please help me? Dr. Hosseini, can you see my video?
Yes, we can see your video now, just now.
Okay. As you know, pelvic lymphadenectomy includes 2 steps. Firstly, the development of the lateral avascular pelvic spaces, and secondly, dissection of the pelvic lymph node dissection. The procedure starts by opening peritoneum from round ligaments going laterally up to infundibulary pelvic ligament. This maneuver allows us to identify by the interaction between ureter and iliac vessel. During the dissection, we should coagulate any bleeding to keep every anatomic landmark clear and excuse me.
We have
usually I use harmonic and bipolar during the dissection. Can you see now?
We have some interruption.
Can you see now, Dr. Hosseini?
Yes, but the quality is low, some low. We have some interruption in the movie.
I know because of the speed of the internet. Yes. After identifying during my dissection, I usually use bipolar and harmonic, and We should coagulate every unnecessary bleeding to keep anatomic landmarks here. And after identifying the ureter, the next step is opening the pararectal space. During the dissection of the pararectal space, only minimal bleeding should occur. And in order to achieve this goal, we should be just lateral and parallel to the ureter. And after that, the first organ that crosses this space is uterine artery. This is the lateral pararectal space of LATSCO, and this is uterine artery. And in this the picture, you can see the medial pararectal space or Okobayashi space. In Okobayashi space, we have hypogastric nerve, and we should keep it safe. The next step is opening the paraphysical space. The main reference for opening the paraphysical space is obliterated umbilical ligament. And as you can see here, the correct movement to prevent any unnecessary bleeding during the dissection of this space is being lateral and parallel to the uterine artery. You can see medial paraphysical space here, medial to the obliterated umbilical ligament, and the lateral paraphysical space is lateral to the umbilical ligament. In the lateral paraphysical space, we can explore obturator nerve, obturator vessels, and we should take Rodden. This is the last final view of the pelvic vascular spaces dissection. After this step, we should remove pelvic lymph node. As you know, the point of the common iliac bifurcation is considered to the starting of the pelvic lymph node dissection. And after that, we will separate external iliac artery from the psoas muscle. At this moment, we can see genitofemoral nerve. We should and after that, we take all the lymphatic tissue and push them up towards the pubic bone. And the upper or caudal limit for pelvic lymph node dissection, as you can see in this picture, is the deep circumflex iliac vein. You can see in this picture, I highlighted it. And you can see here. And after that, we move all the lymphatic tissue medially and below the iliac vessels. And in the below the iliac vein, we can find obturator nerve. We sweep all the lymphatic tissue from the obturator nerve and push all tissue towards the common iliac bifurcations. And we will try to catch everything in black and put everything into the endobag and remove it. Here you can see the pelvic bone. We are trying to sweep all the lymphatic tissue from the obturator nerve and free obturator nerve from the lymphatic tissue, and push everything towards the common iliac bifurcation. And remove everything in black, put them into the endobag and remove it. This is the final view of the dissection for pelvic lymph. I hope to enjoy this video.
Thank you very much, Dr. Hashemi. Do uterine manipulator have any role? It's a perfect job. Do uterine manipulator have any role in spreading and recurrence of the cancer? Do you think this is a different?
Excuse me. As I told you in my as I told you in my lecture, according to Lymph study, you know, the presence of endometrial cancer cells in peritoneal cavity, there is no any, you know, negative impact on the overall survival or progression-free survival of the patients. You know, it doesn't an important issue. And in endometrial cancer, but not in other cancers such as ovarian cancer or cervical cancer.
Yes. Thank you. I will check if there is any question from audience. Any question from audience? Thank you very much, Dr. Hashemi.
You're welcome. You're welcome.
Thank you. Our next lecture from Dr. Kohler. Dr. Kohler, are you joining us? Dr. Kirsten Kohler. Dr. Azadi, can we have your lecture for the next lecture?
Sure.
Dr. Azadi is the Chief Advisor, Associate Professor, Director of Minimally Invasive and Robotic Surgery and Gynecologic Miss Fellowship from Yale School of Medicine in USA. It's our honor to have you for your lecture in our webinar. Dr. Azadi, does the no-look, no-touch technique is an endpoint for debates on poor outcome of laparoscopic surgery in cervical cancer?
Thank you. Thank you very much for a nice introduction, and it is really thank the committee and Tehran University for inviting me to this webinar. It's really my pleasure to be here. And as you said, my talk is about no touch, no look. I guess that's a nice title you guys choose. That was great. I have nothing to disclose for this talk. And just a quick epidemiology of the cervical cancer, at least in the United States before 1950s, cervical cancer was a major cause of cancer death in female in the United States. But with widespread use of pap smear, this dropped dramatically. Number of cervical cancer dropped. But in 1990s, the number is started increasing. That's really related probably to, sorry, this thing keep going. It's related to the cultural revolution and increased HPV infection and smoking. But we hope that with the widespread use of the HPV vaccination, that would probably improve. As you all know, WHO made the pledge in 2018 to eliminate the cervical cancer globally. And recently, just in November of last year, they gave this global strategy toward the elimination of cancer. And actually, 194 countries signed in. That's a dramatic achievement. But even though cervical cancer is really preventive disease, unfortunately, about greater than 500,000 cervical cancer still reported worldwide. But most of them, about 85% of them is really in the developing country, about 15% in developed country. Actually, China accounts for about 20% of all of the cervical cancer worldwide. That's why a lot of cervical cancer study gonna come from China from now on. And about 300,000 people unfortunately still die from cervical cancer. That makes it a really important disease and something that we need to really tackle hard. When I put that, and I think as a general rule, everybody puts the cervical cancer in 3 different categories. I don't know why my slides keep going, but if you look at from bottom up, you look at the metastatic cancer, we all agree that the systemic chemotherapy and radiation just used as a palliative therapy. When you look at number 2, locally advanced cancer, there are a lot of level 1 data study and multiple randomized trial that chemoradiation is the preferred way. Obviously, stage 1B2 to 2A, still you could do surgery, but preferred way remains the chemoradiation. But if you look at the early stage, which is the topic of this talk, is really can be managed, early one can be managed with cone biopsy or simple hysterectomy. fertility sparing surgery is a very important topic because about 40% of the early cancer happens in the younger than age 40. They still desire fertility. And I believe Professor Kohler was going to talk about fertility sparing surgery. But we all agree that with the stage 1B, radical hysterectomy and radiation therapy has equivalent oncological results. But worldwide, surgery preferred, and radical hysterectomy is the way to do it. And the question remains, should we do it abdominally? Should we use minimally invasive? That's the major question. But the study just recently, and their group showed in just recently published, if you look at the stage 1B1, even the less than 2 centimeter, if you do a simple hysterectomy instead of radical hysterectomy, there was 55% increased risk of recurrence. And that really makes the radical hysterectomy standard of the care for stage 1B1. Obviously, you could use radiation, but surgically radical hysterectomy is the way to go. But the laparoscopic surgery, as already mentioned by Professor Hashemi, was incorporated to the management of the gynecologic cancer. Professor Kurlo and their group were really the early adopter of the laparoscopic surgery. In 1991, they published the lymphadenectomy. Professor Darjan in 1993, and Fowler and their group in Minnesota showed the lymph node dissection. But to my knowledge, Sina Najat was reported the first radical hysterectomy, which is really credit goes to him. Here we go. But laparoscopic surgery got incorporated to the management of cervical cancer. We have a lot of level 3 and definitely a lot of level 2 data about the robotic surgery and laparoscopic surgery in management of the cervical cancer. There are 2 of the major studies about the robotic, and you see there are a significant number of the patient with robotic surgery versus abdominal surgery radical, and show the equivalent results in the cervical cancer and better surgical outcome. There are also data about laparoscopic surgery. Also, laparoscopic surgery show the same results. Laparoscopic radical hysterectomy has the same results as the open surgery for management of the cervical cancer. But one important thing that showed the laparoscopic surgery actually has a shorter operative time compared to robotic. I personally think laparoscopic is better than robotic, but really that should remain the preference of the surgeon. They want to use robot or laparoscope. That should be up to them. And there are at least 3 large meta-analysis that shows also the same thing. There's a large number of patients. One of them has 2 of them have more than 1,000 patients. They looked at laparoscopic, robotic, and open surgery. Still showed that the minimal invasive surgery oncologic outcome is equivalent to the open surgery and better surgical outcome. And we had a lot of, but we really, before 2018, we didn't have any level 1 data for cervical cancer. But we do have level 1 data in the just presented by Professor Hashemi, that lab 2 data, and also other randomized trial in endometrial cancer that minimally invasive was equivalent to the open surgery and oncologic outcome. And also we have a data in colorectal and gastric surgery that minimally invasive in the management of the cancer is equivalent. With all this data, most of the institution and large center really started using laparoscopy and minimal invasive and became a main management of the cervical cancer. And the mostly cervical cancer was managed by minimal invasive surgery. But however, as you all aware, in 2018, there was 2 major studies that published in New England Journal of Medicine. One of them looked at the Sears data in the United States. From the time that minimal invasive surgery was incorporated into our practice, we showed that there was significant increases in the mortality rate. But the other major study was the Ramirez study, which is probably worth to quickly go over it. They basically looked at the 320 patients in minimal invasive group, but about 85% of them were laparoscopic, and 320 patients had an open radical surgery. And most of them were stage 1B1, and they randomly went to the minimal invasive versus the open surgery. But the surprising data that really sent a shockwave through the oncologic community showed that the 3-year disease survival and the overall survival was significantly less. But most important finding, I think, in my opinion, was that there was 4 times more local recurrence in their study. That was really a major finding. And when you look at this Ramirez trial that was named as the LAC trial, that's how we name it now. But the most important finding was that really showed increased pelvic recurrence and paraperitoneal carcinomatosis. That's the main finding of this study that everybody agrees on it. But to my surprise, and most people's surprise, did not show any improving quality life. That's the main reason to use the minimal invasive surgery to improve the quality life. But their study did not show any improvement. That was a major surprise. But there are other studies that looked at the same thing. One of the major studies, a European study, they looked at 126 institutions in Europe in 29 countries. There was retrospective data. They looked at 220 laparoscopic radical hysterectomy. They had 63 robotic radical hysterectomy, and they had 400 abdominal. When they looked at, they also showed that the minimally invasive surgery had a higher risk of relapse and higher risk of death. There was another study that showed really there is a problem. There is a shortcoming of minimally invasive surgery. Just in the last AAGL meeting, Italian group, they looked at it differently. They looked at all of their patients had abdominal versus laparoscopic. They looked at the patients that had a recurrence. They found 35 patients with the laparoscopic case that had recurrence. They matched it 2-to-1 to 70 abdominal radical hysterectomy that had a recurrence. They made the group homogeneously. And they showed also there was significant increased risk of intrapelvic recurrence and peritoneal carcinomatosis. These two studies also agree with the LAC trial, and there was a disease-free survival. And as I said, we didn't have any level data. This was the first time we had a level 1 data randomized trial in the radical hysterectomy. But to have a good randomized trial, you have to have really good design. There has been multiple authors question the design of LAC trial. But I'm not going to go through that because that's not topic of this talk. But whatever question about the validity, but we have to give a major credit to the LAC trial, because for first time they showed that we have a shortcoming of minimally invasive in radical hysterectomy that was increased local recurrence, and also agreed with other authors. And most people believe that that causes the poor prognosis. And there has been multiple reasons for that. One of them is due to CO2 insufflation, other one using urine manipulator, and actually training of the surgeon, and also experience of surgeon, which is hard to prove. And the last thing is most important is the colpotomy and exposure of the tumor to peritoneal cavity. That's really the main reason. If you go one by one and look at it, if you look at carbon dioxide, there is a good animal study. There are multiple animal studies that is a significant. Waltz group, when they had a mice, they exposed the peritoneal surface to CO2 gas, and they put a tumor cell, and they showed that the tumor cell became more adhesive and more invasive. And we know adhesiveness and invasive is two major components of the metastasis. And that really makes the tumor more aggressive. What we do when we look at the clinical studies, obviously in endometrial cancer, colorectal cancer, and gastric cancer did not make any difference. But most important is in those tumors are confined tumor. They're within the lumen. They are not in the peritoneal cavity. Perhaps for cervical cancer, if you don't expose the tumor in the peritoneal cavity, that shouldn't even have effect. But this would be a major issue in the ovarian cancer, because we routinely use a laparoscopy in ovarian cancer debulking. I believe that would be a major issue that needs to be addressed in future. But I would leave that to, we do have a couple of talks about ovarian debulking, see if the CO2 gas clinically has anything. But we really don't have a very good clinical study to look at the peritoneal carcinomatosis and effect of CO2 gas. Urine manipulator is actually interesting. As you already mentioned, in endometrial cancer, there was no difference. But we do have a data in cervical cancer that lymphovascular space invasion increases the risk of pelvic lymph metastasis and also worsens the prognosis in cervical cancer. The manipulator doesn't really increase the risk of the lymphovascular space invasion. There is a good data that that's not the case. There is a Professor Liu and their group, they just published the data. They looked at the 350 laparoscopic radical versus abdominal radical. When they looked at, there was no difference in lymphovascular space invasion, and they used the manipulator in their laparoscopic thing. In our group, I never use urine manipulator. I haven't used urine manipulator for the last 20 years, not for cancer or benign cases. And my partners always use urine manipulator. What they do, they ligate the tube before they put the manipulator. Our group, we looked at the difference. There was no difference in the peritoneal cytology or lymphovascular space invasion. But one of our ex-fellows, Dr. Saifi, even went further, and they looked at actually pseudovascular invasion to see if they makes a difference. They also, same thing, they looked at the group with the manipulator and without manipulator. There was absolute no difference in the thing. Therefore, I think there are good data in the literature that shows using the urine manipulator does not really increase the risk of lymphovascular space invasion. But the other problem with the manipulator is also when you use it with tumor, probably would manipulate the tumor, slough off the tumor, and you have more tumor in the vagina. And if you perhaps open the vagina, you have more tumor to expose to peritoneal cavity. I think that's probably true, and we don't have a good data to disprove that. In my opinion, is that I don't know why uterine manipulator used in the cancer probably should not be used, but at least not use it when you have a gross tumor. Macroscopic tumor is fine to use it, but if there is a gross tumor in the cervix, why would anybody put the manipulator in the cervix and break down that tumor? But again, I think as long as you have it contained, that's probably not the issue. I'm not going to go over the studies shows the same thing. Using manipulator did not make a difference. I think other thing is the experience of the surgeon. That's really hard to prove. There's not a lot of data in literature to look at that, but we can look at a couple of studies. This is a study from French group. They just did a retrospective look at their, they had about 34 abdominal radical hysterectomy and 61 minimally invasive radical hysterectomy. And but more than half of them were more than 2 centimeter tumor. They also showed no difference in overall survival or disease-free survival. And French people, in my opinion, they're very experienced surgeon and the cancer managed centralized. That shows that maybe experience has something to do with it. And also, if you look at the Danish study, what they did from the time that they had the robot incorporate their care, they also, the tumors done, the cancers done in the centralized area, they all use robot. When they compared the data using a robot in the central place versus abdominal, again, there was no difference, but also they did not use uterine manipulator. These two studies kind of points to the thing that really having a centralized care of the cancer and also having experienced surgeon probably makes a difference in management of the cervical cancer. But the most important one is the colpotomy. I think everybody agrees that colpotomy and exposure of the tumor to peritoneal cavity is probably a significant factor. And if you look at Matsui from Japanese data, they looked at the Japanese GOG data. And when they did a washing before the abdominal radical hysterectomy. That was a prospective data, but they even retrospectively looked at the cytology. The patients who had a positive cytology, they had a decreased survival in early cervical cancer. This data shows that if you have positive washing, probably peritoneal cancer in the peritoneal surface that worsens the prognosis. This is really about the patient that already had the cytology positive. Is that really same as exposing the peritoneum at the time of surgery? We really don't know, but at least putting the tumor in the peritoneal surface has some indication that worsens the prognosis. And really, again, this has been a shortcoming on minimally invasive. There are multiple studies that agreed that we have a shortcoming, and the other studies that really looked at how to prevent it. Again, uterine manipulator use remains controversial. I think should not be used in the patient with the tumor, visible tumor. That really doesn't make sense. But to contain the vagina, those are basically the later studies that looked at it. There are two ways of doing it. One of them extracorporeal colpotomy, other one intracorporeal. There are multiple studies about that. One of the major studies of Professor Kohler, which in Germany, they basically did what you do to the vaginal radical triglectomy. You grab the vagina where you like to cut the margin, you put a suture across it and close the vagina. Then you do your laparoscopic assisted vaginal hysterectomy or do vaginal assisted laparoscopic radical hysterectomy. And basically what they show, excellent results. The results where they showed a 4.5-year disease-free survival was exactly same as the one in the open surgery LAC trial. That indicates that if you have basically, if you call it no-see method, if you don't look at the tumor, and they didn't use a manipulator, obviously no touch. No touch remains controversial, but no-see shows that really there is the same survival with this. And also Kanu and their group, they did the same thing, a little bit differently. They opened the vagina and they dissect the vagina and then basically close the vagina on top of the cervix, and they did their laparoscopic radical hysterectomy. And they also showed that their 5-year survival was excellent. That means really they also didn't use manipulator, obviously there was no reason to do it. They also showed that if you confine the tumor, not expose the tumor to peritoneal cavity, you probably have the same results. And you can basically eliminate the shortcoming of this minimally invasive. But not everybody is a good vaginal surgeon. Unfortunately, at least in the US, a lot of GYN oncologists are not a very good laparoscopic vaginal surgeon. And also some patients are not candidate because a short vagina or narrow vagina, whatever the reason. But the other methods are intracorporeal. There are multiple studies in literature talking the way to do it from above. Stapling the vagina has become common. And in the AAGL meeting, the South Korean group actually have a prospective study. they're looking at the patient prospectively with the cervical cancer. They do the washing before and washing during and washing after stapling to see if actually stapling decreases the cytology positive. I believe they had 3 patients so far and they presented and showed no difference. That means stapling is really can be a method to prevent spillage of the tumor. What I find out for us, stapling the tumor is fine in the small tumor and also fine in the microscopic tumor. At least in my hand, it's very, very hard to have a large tumor to put staple across this, but especially if you have a fungating tumor, it's very difficult to make sure you don't put staple against the tumor, make sure tumor is confined above. But we adopted, and a lot of other people have published, putting the purse string suture below the tumor. And this is one of our fellow presented in AAGL. What we do, we basically put a purse string below the tumor, and then we cut the vagina before. You don't have to use a probe, but you can use a vaginal probe before, after you put the purse string and cut the vagina, and you remove it. And really to prove this shortcoming of the minimally invasive surgery and also method to prevent it is really we need a randomized trial. And there are only 2 trials that are going on in the Swedish study and Chinese trial. Again, I'm not going to go over details just for the time, but we're really in the need of good randomized trial, prospective randomized trials to have. Really, we have to make sure it's designed very well, done in the specialized center by people who are very well trained to really prove if there is a shortcoming of the minimally invasive and also to solve it. And if you have time, I'm just going to do a quick video of ours. This worked. Yeah, this is a case actually we did a couple of weeks ago, and one of the fellows are nice enough to do this video. But the way I do it, I inject a little bit of methylene blue in the anterior vagina and the posterior vagina at the site that I want to take the vagina off. And once we come to that blue part, I have somebody put the finger from below, make sure we have a good distance at the methylene blue side, and we put a purse string around the vagina, and we use either 0 or the number 1 monofilament suture, usually Prolene or Maxon or whatever you like. And what I found that we don't have a lot of cervical cancer East Coast. We really don't get a lot of this. But what I found out that, but again, before I cut the vagina, I have somebody go below and irrigate the vagina completely, make sure there is no macroscopic tumor. We do extensive irrigation. As I said, I don't use any manipulator, but you can use a probe, but really you don't need to. You can open the vagina, and this way, hopefully you don't have any exposure. Then we remove the uterus. And after we close the vagina, we extensively irrigate the pelvis again. And what I found out with the 0 suture is really sometimes the thick vagina is hard to make a tight closure. I think from now on, I probably use a Merceline tape like we're using in abdominal cercologists, but I haven't done that yet. I think you need something to be able to do it. But if you see that that's a methylene blue mark that we put in there, and I put one in the front, that way I know exactly where to cut. And again, after we put the purse string, we irrigate the vagina, make sure there is no macroscopic tumor in the vagina. We cut the vagina. And after we remove it, close the vagina, and we can irrigate it to make sure we don't have any exposure. And again, to just conclude my talk, and obviously minimally invasive surgery is not a problem. The problem is really the surgical technique. And we really have to be careful when we do these cases. I think no touch is important. I think uterine manipulator is a significant thing because a lot of people are used to uterine manipulator and they like it to their cases. I think in microscopic tumor it's okay to use it, but I don't think you should use it in the tumor that has actually visible, because it does break down the tumor, increases the number of the cells in the vagina. But again, if you contain it, probably not an issue, but it would increase the peritoneal carcinomatosis. But I think no C method is the important thing. We have to make sure we contain the tumor. And what we do with our patients, we talk about the data, we explain the entire data, shortcoming of the data of the minimally invasive and how we try to prevent it. Make sure our patients understand that, they give informed consent. And if they want to do abdominal radical, we do that, but otherwise we go ahead and do it minimally invasive. And about 85% of our patients choose to do minimally invasive. Again, thank you very much for the invitation, and it was very nice to be here. Thank you.
Thank you very much. It was an astonishing presentation. Thank you very much. Is there any question from audience? You can type your question if there is any question. The next lecture is from Professor Denis Carlo from Rome, Italy. Professor Carlo is the professor of obstetric gynecology and oncology, Gemelli University Hospital, the past president of the European Society of Gynecological Oncology, with a great experience and knowledge in extraperitoneal lymphadenectomy. Professor Carlo, we are ready to hear your speech about extraperitoneal lymphadenectomy.
Thank you very much. Good afternoon. Hi, Masoud. Thank you very much for the invitation. I would much prefer to be with you physically. I love your country, but it is as it is. It's the days as we are. We have to work like this. So my talk is about extraperitoneal endoscopic surgery in gynecologic oncology. Yes, I have no conflict of interest to declare without surprise. I will put, are you in full screen? Is that okay for you?
No, it's not full screen now.
Okay, so because sorry, I have to change something. The window is not accessible. Okay, anyway, sorry about that, but I think it's readable. Okay, so it's clearly this extraperitoneal approach is a logical approach for many types of surgery, and typically it used to be the urologist's approach, and it has been adopted by my mentor Daniel Dargent, who was aware of this. And initially it was an open approach, and early in the history of aortic lymphadenectomies there has been also an extraperitoneal aortic dissection open, but it has been replaced by a minimal invasive approach with many advantages compared to laparoscopy. No issues with the bowel. There are so many issues with the bowel with laparoscopy that I don't have to make the list with you. It is clearly more adapted to obese patients for the same reasons, and it is, you will see, much more ergonomic. A few drawbacks: CO2 reabsorption is not an issue if your anesthesiologist is aware, just have to ventilate more. And also the lymphocyte formation, which is much more frequent just because the space is closed. But one of the options is to open the space and create a fenestration in the peritoneum at the end of the operation. And using also all the techniques for a careful lymph vessel sealing. And clearly what I will present to you is exactly the same surgery that we all do, just with a different perspective. It's a lateral vision. And for this reason, there is a need for a specific learning curve, but the learning curve is not that much an issue. Back to history, the first publication on this topic came from the United States. These people did only a few cases and never published again, but they were the ones who did the real first cases. And only later, my team, when I was in Lille in northern France, and with Daniel Dargent, who was in Lyon, we adopted the technique and we used it initially for the staging of advanced cervical carcinoma with the objective to tailor the radiation therapy field, just to be aware of the status of the aortic node. It was before the PET scan era, but after the PET scan era, there is still a need for more pathologic information on the aortic node. How does it work? We will start with the standard anatomy. And with the very start of the operation, we start with, because we are gynecologists, with a trans-peritoneal diagnostic laparoscopy, always useful to see what happens in the peritoneum. But in cases with extensive adhesions, we can do without if necessary. The operation starts with a digital preparation of the extraperitoneal space. And this preparation is made with the finger, but the laparoscope can check it, you will see. Then we place trocars in the left lateral flank under finger control. And finally, we insufflate the extraperitoneal space while exsufflating the peritoneum. And you see here the placement of trocars. This incision is the first one we make. With this incision, we create the space and we develop the space with the finger, but later we place the endoscope. It's a 10, 12 millimeter trocars you see here. We use a balloon trocar because after the incision and the work of the finger, the space is too large, so there can be a leak, so the balloon is necessary. And after this, we place 2 additional trocars lateral in the left flank of the patient. One is a 10 millimeter trocar, the other one is a 5 millimeter, but both are in the extraperitoneal space. And this is the position of the surgeon and of the patient. As you can see here, the surgeon and the assistant stand lateral to the patient on our left side and look at the strainer on the other side. And they are standing up with the table elevated so that they work, both of them work horizontally. And that's the reason why it is so ergonomic surgery. No backache after this kind of surgery. And this is how it works. You see how the finger has been placed through the first incision, which is medial to the iliac spine, and develops the space, palpating the psoas and also palpating the common iliac artery. One can feel the beating of the common iliac artery, and you see on these pictures the finger seen from the laparoscopic vision. So everything is under control with both the finger, we are gynecologists, and two, with the vision, we are gynecologic surgeons. And once this is done, one of these trocars are placed, we insufflate the extraperitoneal space, exsufflate the peritoneum just to avoid any counter pressure from the peritoneum. And this is the first vision we have. And we see the left common iliac artery, which we have already palpated, so we know it is there. And generally, the left ureter is here, crossing the left common iliac artery and the bifurcation of the common iliac. And the first step of the operation is to find the space to develop the extraperitoneal space between the vessels and the ureter. So the right plane is here, and elevation of the ureter is really a mainstay of this operation. No way going above the ureter. It's a wrong plane. Once this is done, we can further develop the space in 2 directions. In the cephalad direction, following the psoas muscle, this is the psoas muscle, up to the level of the kidney and of the renal vessels. And to achieve and to complete this, we have to break the perirenal fascia you see here. And this is the kidney with the fats around the kidney. And this is the perirenal fascia. So we have to completely clean the psoas muscle. Going medially and also going to the left side, we develop the space under the ureters up to the point we see the other, actually the right extraperitoneal space. And you see how we can see on the right, starting from the left side. And that's the objective of this operation, is to, of course, to see everything and to dissect. And this is the anatomy after the dissection of the nose. This is the aorta. We can push on the aorta in order to see the vena cava and the intra-aortical, aorticocaval, area between the 2 vessels. Here you can see how we can explore the left, the right side of the dissection, which the vena cava and the right ovarian vein flowing into the vena cava and the right ureter. And the limit of this space, which is inframesenteric, is the inferior mesenteric artery. And again, you see here on the other side, both the right ureter and the ovarian vessels, and also the right ovarian vessels have to be elevated to gain access to the right space and to be able to remove safely the nodes. And removing the nodes is straightforward. It's exactly the same technique that by laparoscopy. We mainly used multifunction instruments because they are much more comfortable. We don't have to change all the time instruments, and we can cauterize, cut, or dissect and cut with the same instruments. Going further and developing in a cephalic direction in front of the aorta, you see that we can gain access to the left renal vein, which is a very important landmark. It is the upper limit of our dissection. Again, the right ovarian vein, but for the first time here, you see the left ovarian pedicle flooding into the left renal vein, and this anatomical anastomosis between the renal vein and the lumbar system, which is potentially dangerous. But generally, you can see here because it's exactly the opposite of the left ovarian vein. And this is how it works for the infrarenal area. And finally, we can also go in the caudal direction, because for us, for diagnostic reasons, the common iliac area has exactly the same significance as the aortic area. And we feel that we have to give radiation therapy in the aortic area if the nodes in this area are diseased. So it's necessary to go to the common iliac area, and you see that it is possible using this technique. Again, elevating the ureter, again, I repeated, the mainstay of this operation. This is the ureter, but we can go in front of the common iliac vein, then in front of the promontory. You see here the presacral veins, and go to the right side and see the common iliac and even the bifurcation of the right common iliac artery. With a closer view, this is how the vena cava starts with the meeting of the two common iliac veins in front of the sacral promontory. So this is the normal anatomy, but I always teach what I call the advanced anatomy. We have to know more than the locations of the vessels and the ureter. So the first is about nerve anatomy. And the first important landmark is the genitofemoral nerve. So this nerve runs in front of the psoas muscle, and it would be a mistake to elevate this nerve, thinking that you are elevating the ureter. And its Y shape is absolutely typical. And if we divide these nerves, there can be some long-term pain and dysesthesia effects. So it's not good. Another important anatomical landmark is the sympathetic chain. You see here the aorta, you see here the psoas muscle. This is the left paraortic area. And in between the psoas and the aorta, you can see the sympathetic chain with nodes. And it's very important not to be confused, to remove the nodes, thinking that they are lymph nodes. Actually, there is a typical nerve chain with the superior hypogastric nerve starting here and the chain going up to the thorax. So that's a really very important landmark. Another important landmark are all these nerves coming from the sympathetic chain that you see here to the mesenteric plexus. And this is the mesenteric plexus. And you see that some fibers run from the sympathetic chain to the mesenteric nerves. We gynecologists divide these nerves, but the urologist retains them, spares them, because they are important for the sexual function of men. And finally, this nerve joining the sympathetic chain to the mesenteric plexus is a very important landmark. You see there is invariably a very big nerve fiber, which is a landmark for the inferior mesenteric artery. And this fiber has to be divided if we want to gain access to the upper area, to the left renal vein, and also is a very important landmark. And you see on this picture, a node in place, and that is the node we have to remove. About advanced anatomy, you have also absolutely to be aware of the details of normal anatomy and later of abnormal anatomy. Normal anatomy includes the left and right ovarian vessels. They leave the aorta, and it's really dangerous. If you divide them at the aorta, you can still coagulate with bipolar cautery, but it's better to control them in advance at a distance for the aorta and create a stump. This is the left renal vein. This is the inferior mesenteric artery. Renal arteries are also important landmark because they are usually cephalic to the vein, to the renal vein, but not always. So these veins can be below the left renal vein. So I always say to my fellow, beware of beating nodes, because it looks like a node, but it is beating, and it is the left renal artery. Also, if you dissect too far away and further to the left renal vein, you can see the superior mesenteric artery, and it would be extremely dangerous and even lethal to the patient to injure the superior mesenteric artery. If we also go to the retro-aortic area, which we no longer do routinely, you have to be aware that there are, of course, lumbar arteries, and these lumbar arteries also can be controlled with bipolar cautery if necessary. And this is another vision of the anatomy, because as you can see, we can see the vena cava from below the aorta when it is necessary and when there are enlarged nodes in this area, which is not common. But it's a way to dissect the inter-aorticocaval nodes. Also, normal anatomy is this lumbar network with the renal vein and with the azygos vein. You see here the azygos vein on this at this point. Sorry. Okay, that's the azygos vein, and the anastomosis, and also another lumbar vein. Another feature of the normal anatomy is what is usually called the Fellows vessel, which is a small vessel joining the vena cava to the precaval lymph nodes. I rather call it the professor's vessel because the professor is rushing, while the fellow is much more prudent. But anyway, what we have to realize is that with this situation starting lateral from the left side, you see much better this vessel starting, and you can control it at a distance from the vena cava. No anatomical anatomies. Be aware that there may be a double vena cava in front of you. One example, another example. But also retain the message that it's impossible to do this kind of surgery without previous imaging. And you have to check pre-operatively if there is or not a double vena cava. And it's the same for retro-aortic renal vein, which creates puzzling anatomical situations unless you are already aware with imaging. So it's really extremely important to stress this. And finally, you can find accessory renal arteries in many situations. So another message to my fellow is never divide what you don't know, what you cannot name. And even in some situations, for example here, an accessory renal artery starts from the common iliac artery, which is really uncommon, but can happen. Just a few words about the right-sided approach. We can approach from the right side. It's exactly symmetrical, but you see the inferior vena cava on this side. And this is the status with the limit of the vena cava and the two common iliac arteries. Sometimes we remove left-sided nodes, especially recurrent nodes, using this. And lately, I must say more than 12 or 15, and maybe 15 years, we have extended this dissection to left pelvic side wall. And it is absolutely possible to remove the iliac and pelvic nodes using the same approach. You see here the genitofemoral nerve, the two vessels. You see the ureter going down in the pelvis, the supravesical artery umbilical ligament going up to the abdominal wall. And you see that we can open the paraphysical space. But the best access to remove the nose is to detach the vessels from the pelvic side wall. And here you see the psoas muscle, the external iliac vein, external iliac artery, and genitofemoral nerve. And you see that in between, you can also open the paraphysical space and remove the nodes. And this is, for example, a node, obturator node with the obturator nerve just below. And at the end of the operation, this is the status. And especially in obese patients, it can be interesting to do also this. It works well. There can be some difficulties, and especially this variant, which is an artery going to the psoas muscle. We just have to be aware, not big deal. To go to the right pelvic side wall is a little bit more difficult. We have to prepare this in advance. So it's a slight modification of the placement of trocars that have to be a little bit more medial. And it is not always possible because some patients have a very stiff mesorectum, and it is difficult to move the rectum away from the field. But anyway, in all situations, we can see the bifurcation of the common iliac. This is the external, this is the internal, and the right ureter. So even if we do not completely succeed, we can at least remove these nodes and very easily remove the other nodes, especially in obese patients, when it is not possible to dissect everything. But you can see that sometimes you can see the obturator nerve, and that at the end of the operation, we can see the obturator muscle and down to the obturator foramen. But I insist, it's not always technically possible. So just a few words about the evidence base. We have one experimental randomized study. We have one clinical randomized study starting in 2016 and with very recent results from the Barcelona team. So it was for my team in Lille. We demonstrated that the number of nodes was the same, the duration was the same, but with much less adhesions than after trans-peritoneal laparoscopy. It was a randomized study in the pig model. And the prospective randomized trial that has been initiated and carried out now in Barcelona has compared the operative data of the two techniques, and more or less they found the same outcomes with some conversions either to the trans-peritoneal approach or to laparotomy, which is not our experience. Conversion is extremely infrequent. But at least we have this randomized study in a very good team at the hospital clinic in Barcelona. And we had earlier the same experience, but it's not randomized. It's only a prospective recording of our cases. So we published when we had 1,000 patients operated with a number of extraperitoneal dissections. So you see here we had performed at that time already many operations. And you see that comparing trans-peritoneal and extraperitoneal approaches, both for pelvic and aortic, shows clearly that the data are more or less the same, with the same number of nodes retrieved. But what's important to understand is that, and this paper is really very important in this regard, to show that this technique is extremely efficient compared to laparotomy in obese patients. So when the BMI is over 35, much better to use this approach to do the aortic node. So I'm almost done. There is a meta-analysis that showed exactly the same, similar outcomes. So this approach is an acceptable approach. And you see here that intraoperative complication are maybe a little bit less, probably because of the Bowel factor. And I will finish with a very recent publication of the same Barcelona team. So you see here that they have now recently published. Please note this Gynecologic Oncology recent issue in which the Barcelona team has finally found one patient in each group finally found more nodes retrieved via the extraperitoneal approach. You know, it's so convenient, and especially with greater body mass index, that it's not surprising results. So I will finish with indications, because we can use this extraperitoneal approach in many situations. Advanced carcinoma of the cervix for staging purposes, but also for any other indication of aortic dissection. And it's in this case, in endometrial cancer, in ovarian cancer, staging of ovarian cancer, it's included in a combined approach, starting extraperitoneal, because once the peritoneum is open, you can no longer inflate the extraperitoneal space, and finish laparoscopically doing the omentectomy, hysterectomy, and so on. So this is these are the steps of this combined approach: laparoscopy, extraperitoneal dissection, transfer of the trocars in the peritoneal cavity, intraperitoneal steps, and finally, fenestration. And my almost last slide will be about a new development, which I'm not sure it has clinical applications, but we can also do hysterectomies using this approach. And you see here the ureter, and you see the vagina, which has been opened after the hemostasis of the uterine pedicle and of the uterosacral ligament. And at the end of at the beginning of this operation, we just have to see the ureter from the left side and divide the uterine pedicle. But I'm not sure this has so many applications, but you must know that it is feasible. So thank you very much for your attention, really mamnoon. And I would be pleased, if COVID permits, to see you at the ESGO meeting in Prague at the end of this year.
Thank you for your nice presentation and joining us.
Thank you.
The next lecture is from Professor Kohler. Professor Kohler, are you joining us?
Dr. Rossini, can you hear me?
Yes.
I hope you can.
Hear you.
Okay.
Yeah.
Okay.
Dr. Kohler is the full professor, head of the Department of Advanced Operative and Gynecologic Oncology from Alkepins Clinic, Altona, Germany. The title of your presentation is Triglectomy. We are ready to hear your speech.
I'm sorry, Dr. Rossini. At first, I wanted to thank you so much for the invitation. I think I do have a little bit problem to open the screen, and I hope you can see now the presentation very soon. Please give me a short feedback if you can see the screen or not.
Yes, we can see.
Okay, perfect. At first, again, I want to thank you so much for the invitation. It's always a great honor to be invited by you and your colleagues from your lovely country. And at the end of the slides, I want to show you one of the results of our wonderful and fruitful cooperation. The topic of my presentation you gave to me is radical triglectomy, and with great pleasure I want to share with all of you some of the ideas of our of this fertility spurring surgery, because I think it's very important for a young woman to have this opportunity, because these young patients or women are very often highly educated. They are just now socially economic established and have found a partner for their family. And then exactly at this moment, they get a cancer diagnosis. And this is for them a life-changing and of course a potentially life-threatening event. And you have performed a lot of this discussion and discussed the pros and cons of this procedure. The summary is that none of these young women would accept any oncologic compromise or uncertainty, and they all want to have the highest oncologic safety, but also want to have most often the wish to get pregnant in the future. And I'm coming back to my previous speaker, Dennis, best wishes and greetings to you. It is one of our great pioneers in the gynecological oncology, your friend and colleague, Professor Daniel Danjean, who reintroduced the technique of radical triglectomy into Society of Gynecologic Oncology. And also he tried to fix the clear indications for this procedure, and the clear indications which are accepted internationally now are small tumors less than 2 centimeters, the proof of tumor-free lymph nodes, most often done by a frozen section, and free endocervical margin, hopefully more than 5 millimeter. But this is a point of discussion. No atypical histology should be, in no histology, atypical histology, the procedure should be done like a neuroendocrine or clear cell carcinoma, because the recurrence rates are higher in these patients. I'm not a 100% fan of the current available ESGO or European guidelines, which are rather vague in this exactly in this field for fertility sparing treatment. And I come back to this point at the end of the presentation, because as you can read, conization and simple triglectomy are considered as adequate for stages 1A1 and 1A2 for lymph node negative patients. The radical triglectomy, as you can read, can be considered. This is also a rather vague statement, and the radical triglectomy should be performed in patients with lymphovascular positivity and node negativity. Again, the indications are and the borders between these recommendations, in my opinion, are not 100% clear. Again, I come back to this. The first technique that was described by Daniel Danjean was a radical vaginal triglectomy, and we are still doing this procedure up to now. This is, I think, today a standardized technique and consists of 3 parts: a laparoscopic part, with the pelvic lymph node dissection, and if the lymph nodes are considered as tumor-free and frozen section, then you can start to prepare a little bit better for the vaginal part. Meanwhile, you are waiting for the frozen section. That means you can open the rectovaginal space and the vesicovaginal space, and this can be helpful, especially in young patients with a narrow vagina and in patients who haven't delivered a vaginal delivery before. During the vaginal part, you do the resection of the cervix and the vaginal cuff according to a type B radical procedure, and later on you can go back to the laparoscopy to ensure that there's no bleeding, and perform a laparoscopic control, washing, and check of all the intactness of the important organs. Altogether, it is, in my opinion, very standardized techniques. You see in this graph in the left upper side, the green part is the remaining part of the cervix, whereas the part with the here painted tumor in purple, this is a resection line with a dotted black line. In my opinion, the main advantage of this technique that was initially described by Daniel Danjean is that you have a direct control with your finger and the direct palpation. It's the best way, and with the knowledge of the preoperative MRI, especially of the length of the remaining cervix, if there is any residual tumors, localization of it, and the knowledge of the histology of the cone, you can exactly determine how high you have to resect the cervix in order to do the maximum oncologic safety for this patient. At the end of the vaginal part, we always perform a permanent cerclage This is an important step in order to prevent a premature delivery in later pregnancy, and then you close the vagina and readapt the vagina to the remaining cervix. As you can see in this short video clip, the most difficult part during this procedure was always the identification of the ureters in the bladder pillars with the so-called click maneuver. And especially in patients with very narrow vagina, who nulliparous women, this can be very difficult. And I think this was one of the reasons why this technique was never very popular in the community of gynecologic oncologists, and also had a problem with increased rate of urologic complications. And the third aspect is that this step was really difficult to teach, and you need a lot of cases in order to feel confident in this area. And in the most of the centers, this number of trachelectomies is not available to get such proficiency. In order to avoid this, one of my co-workers, Andrea Pleigner, she together with our team developed a modification of this technique that we do during the first part of this procedure, during the laparoscopic part, a very wide opening of the vesicovaginal and cervical space. You see both uterine arteries definitely visible on both sides. And if you go a little bit deeper, here shown in this graph, you can on the distance between the undercrossing of the ureter and its entry to the bladder, you can hunt the ureters on both sides and mark them with a short silicone band. Here's on the right side the ureter, but here's the uterine artery, and here's the bladder. Exactly on this distance, you can find the ureter, put a band on it. As you can see, this is the final situs before we move to the laparoscopic part. And as you can see here, both ureters are clearly marked. And if you go back down to the vaginal part, it's very easy to grasp the silicone bands. And this hopefully can simplify the vaginal part, especially the fear to injure the ureter and to overcome some of the barriers of this technique. These pictures I got from some colleagues. This is in situs after a radical vaginal trachelectomy. You see 2 weeks after the procedure, and the other one is 6 months after trachelectomy. The main problem in this patient is that they have to be followed up by a very experienced colleague who has some experience in this technique, because sometimes it's really difficult to find the entrance in the remaining cervix, because it's direct in the level of the vagina, and sometimes only during the menstruation you can find the entry to the remaining cervix. This is not related. These graphs are not related to the trachelectomy. These are related to the total hysterectomy, but it should be illustrated that of course, also in trachelectomy patients, you should avoid to use any manipulator to perform an adequate surgery. And the much better and oncologic safer way is to close the vaginal cuff as it is described during the radical vaginal hysterectomy. And that's why I think both procedures, the robotic radical trachelectomy and the total laparoscopic radical trachelectomy, have to be handled with very high caution at the moment, because if you use a manipulator to perform this procedure after the publication of the leg trial, this should be handled with very, very high caution. And what remains is the radical vaginal trachelectomy and the radical abdominal trachelectomy. And both do have some problems, because radical vaginal trachelectomy, as shown in the previous slides, hopefully is difficult to learn and to teach. whereas radical abdominal trachelectomy has up to now the lowest fertility rates. And if you go to the available reviews and meta-analysis in fertility, sterility, and in the Lancet Oncology 2016, both published by the French group, you see most procedures were done as a radical vaginal trachelectomy, less than as abdominal trachelectomy, much fewer total laparoscopic and robotic at this time. And the simple trachelectomy and cone is a mixture of small cohorts and case reports. But if you look at the same data, the rate of the pregnancy rate of the abdominal radical trachelectomy is 15% lower than the radical vaginal trachelectomy. That is a significant lower number, and the rate of premature delivery is also lower in the radical vaginal trachelectomy than in the abdominal radical trachelectomy, but double to the simple trachelectomy and cone, and I come back to this aspect a little bit later. All patients that underwent radical trachelectomy have to be considered as a high-risk pregnancy if they get pregnant, and they have to be handled with very caution during the entire time of pregnancy, because they are at high risk for ascending infections due to the shortened remaining cervix and the probably the permanent cerclage. Up to now, we do have some recommendation, but there's no general agreement for all of these. So it's sometimes a very individual armamentarium of difficult things for these patients, also depending on the length of the remaining cervix, the intactness of the permanent cerclage, vaginal infections, and others. As every surgery can do, there can be possible complications after trachelectomy, and they are summarized in this slide. One of the main problems or two of the main problems that are described is a problem with a permanent cerclage, which is in the literature described up to 10%. In my opinion, a little bit too high, this percentage. And this can be avoided. Sometimes this permanent cerclage or part of it is visible in the vagina, and it is removed from other colleagues because they don't think it's a remaining suture after the procedure. But this can, of course, cause major problems during the planned pregnancy. Another one is the problem of the isthmic stenosis, and this is a relevant problem, especially if no spontaneous pregnancy occurs, and the team of the IVF colleagues have to be helpful and to perform an insemination or any kind of IVF therapy. And for them, it can be very difficult to enter the uterine cavity in cases of isthmic stenosis. Very interestingly for me, it was a very small study looking for 30 patients after radical trachelectomy and evaluated their quality of life. And interesting, 20% of them didn't have any sexual intercourse 20 months postoperatively, which does make a really sense because the procedure is intended to have a baby in the future. And again, this is a contraproductive factor. Sometimes you have to find very unusual solutions. In this patient, there was a repeated cervical stenosis with dilatations under anesthesia because of the hematometer. And in this patient, this was a very individual decision. We placed a vascular stent in order to overcome the cervical stenosis. By the way, in this patient was successful. We removed the stent after 3 or 4 months, and the patient could get pregnant using IVF, and now she has a healthy baby. But again, it's very unusual and not 100% indicated for this situation. But again, you have to be very you have to find sometimes very individual solutions. There's a huge debate about possibility of tailoring the radicality in patients with early cervical cancer. And I agree, this is a huge issue for the future. These tailoring can be done in two directions, either reducing the extent of the lymphadenectomy and going to a sentinel concept. This is one aspect. The other one is, can we reduce the extent of the cervical resection and perform only a simple trachelectomy, which is marked here in green line, or a repeated cone marked with these blue lines in comparison to the dotted resection line of the radical trachelectomy. Only two words to the sentinel concept, which is a totally other aspect of discussion. You can visualize the sentinel node with blue dye or any ink or with ICG. The main problem is a false negative rate. As you can see, this blue node was tumor free and the node directly beneath was tumor containing, and this is always the fear of the procedure. There are two ongoing studies, huge studies. One is the SANTIC study that have finished the recruitment of the patients, and the French Cervical 3 study. And we have to wait for the oncologic data in order and together with the morbidity data in order to get valid data on this concept. I think much better than we do have at the moment. One possible problem can be young women with extensive tattoos on the legs, because you can see this tattoo ink is collected in this pelvic lymph nodes. These are all patients without previous sentinel marking, but you see all these lymph nodes are inked with blue, green, yellow, red, whatever you find on the tattoo, and it can occur that they block the normal lymphatic channels, and then you might get in false oncologic results during a sentinel procedure. That's why we are carefully looking now for the legs, if there are extended tattoos, and we are then very cautious with the sentinel procedure. But again, coming back to the tailoring the resection with respect to the cervix, the one possible procedure is a cone or repeated cone. And if you look to one of the major or the larger cohorts is the Scandinavian group that these colleagues performed a retrospective review of 43 patients, and you see they had to perform in nearly all women a repeated cone in order to be in sound margins, and in 3 patients a third cervical resection. And despite this repeated resections, they found 2 central recurrences. And in the more recently published Italian group with 45 patients in this cohort, they found a recurrence rate of 30%, which is 3 times larger than the recurrence rate in the trachelectomy group. And it's not really true that the conization does not impair the obstetric outcome. This is an often talked argument, because if you see the preterm birth rate, and we know this from large meta-analysis of the treatment of cervical dysplasia, you see patients cone versus no cone have a doubled risk of preterm birth rate. If you perform repeated cone, this is a 3 times higher rate of preterm delivery, and if the cone has a depth of more than 50 millimeters, it's really the same. It's the simple trachelectomy, which is preferred especially by the Canadian group, can be an alternative, but we have very limited data and very small cohorts with different criteria and without any long-term follow-up. And so it's very difficult to say, okay, which are the best criteria to perform a simple instead of radical trachelectomy. That's why, in my opinion, at the moment, it can be changed in the future. The radical trachelectomy has a clear indication. We have large databases for this procedure with a long-term follow-up and a very excellent oncologic outcome, whereas the cone and the simple trachelectomy is currently performed in different indications in small cohorts with a shorter follow-up, and the real recurrence rate differs between 0 and 15%. It's too unclear at the moment to recommend it to the patient. In conclusion, I think the radical trachelectomy, we do it bivaginal or radical vaginal trachelectomy, has a clear indication. It's a standardized technique with a low complication rate, has a low recurrence rate, and a good chance to get pregnant. I really agree that the radicality of the lymph node dissection as well as the parametrectomy hopefully can be individualized in this future, but we do need exact criteria for less radical surgery, and they are not defined yet. And that's why this fertility spurring surgery should be done in centers that offer all techniques from cone to radical trachelectomy in order to avoid a bias, because they recommend only one procedure because they cannot perform the other ones. I want to finish with this nice pictures. I got it from the colleagues from Tehran, because this is a very successful, and it was really a huge honor and a surprise for me to meet again this young lady in whom we have performed the radical vaginal trachelectomy in Tehran. I was so surprised and so happy. She as well, she has a healthy baby, and this is the best argument for this procedure. Thank you much. Thank you again for your invitation and the great honor to participate in your Congress.
Thank you for your nice presentation and accepting our invitation.
Thank you so much, and good luck for the remaining Congress.
Thank you. I hope to see you again in Tehran very soon.
Me too.
The next presentation is from Dr. Shailesh Pantambekar. Dr. Shailesh, are you joining us? Are you hearing me?
Hello.
Hello.
Yeah, sir will be joining in just 5 minutes.
Just 5 minutes?
Yes.
We waiting for you, or we turn to the next lecture?
Dr. Hosseini, if that would be okay, we can see a video, yes. And after that, we can hear Dr. Shailesh.
Yes, or we can have the lecture of Dr. Soleimani.
That's up to you, your decision.
Yes. Dr. Soleimani, are you ready for your lecture?
No, actually, there was one more lecture before sir's lecture. That's why he is not here in the schedule.
Yeah, I mean, I could start. I could crack on if you want me to.
Dr. Shailesh, we will continue with.
Okay. Yeah. It will be okay if he goes ahead with the presentation. No problem.
Yes. The next presentation is from Dr. Houman Soleimani Majd, the consultant in gynecological oncology in Churchill Hospital, Oxford University Hospital, UK. Dr. Soleimani, I have seen your perfect job in recurrence surgery, and we are ready to hear your lecture about the surgery in recurrence cancer.
Okay, it's my pleasure. Just bear with me. I'm trying to share with you my presentation. Please let me know when it's shared. It should be okay. Now share screen. Okay. Please let me know if you have my presentation shared. Now
Yes, we see, but not in full screen mode.
Okay, it should be fine.
Yes.
Is that correct? Okay, thank you very much for inviting me today. It's such a pleasure and honor to be able to present in this forum. It's always a lot of pressure on you following up eminent speakers and very known gynecological colleagues around the world, Professor Azodi, Professor Kerley, and also Professor Keller, all very inspiring talks. I personally have enjoyed a lot. I'm sure the rest of your audience also have learned a lot. I mean, it's a very difficult time to talk about the role of minimal access surgery after LAC trial. I think a lot of us have faced a lot of trouble these days performing these surgeries because of the critics and also colleagues who are very much pro practicing evidence-based medicine, which is correct. So moving forward, from now on, the gynecological community need to be really critically appraising their work and also be very mindful of the application of their surgical techniques and also be very willing to take part in prospective studies. So the talk you have given me is the role of minimal access surgery in the management of gynecological cancer recurrence. I have tried not to talk about things which I thought my colleagues would have discussed or we will discuss. Hence, I have kept it concise and crisp to the task. I would like to start by talking about the application of laparoscopy in the management of recurrence. So far, our experience in Oxford Cancer Center, Churchill Hospital, is that this laparoscopy is done for uterine, cervical, and ovarian cancer. And it's needless to say that the role of minimal access surgery in all gynecological oncological malignancies has been well established. We heard from Professor Keller and Professor Azodi. Operating time, blood loss, intraoperative complications, hospital stay, blood transfusion, and also postoperative complication by far is in favor of minimal access surgery. There's no doubt about that. We know that it is well established. When it comes to the application of minimal access surgery in gynecology oncology, one should know that surgical skills is quite important. We need to spend years and years to practice both open and laparoscopic surgery to be able to deliver a safe and oncologically sound minimal access approach. So the application of oncological principles is relevant to laparoscopy as much as it's relevant and pertinent to open surgery. And when it comes to doing any minimal access surgery in the setting of recurrence, we need to go back and look at what we normally do when it's a primary surgery. And that there's so many studies published. I don't want to bore you with that, but the tumor smellage is one thing that we should all try to avoid and be very mindful and careful. And be aware that it is safe to perform minimal access surgery. We know in experienced hands, the outcomes are very good. We have to have a thorough anatomical and oncological knowledge, and we need to have a very good understanding of the surgical outcomes, a very robust governance, and also data collection of our morbidity and mortalities in what we do is quite important. And we make sure that the patients are in the center of the care we provide and not just trying to give a go and do a laparoscopy for the sake of doing that. In summary, what we are doing these days in the concept of the recurrence is the uterine cervical cancer. We do routinely laparoscopic assessment as part of planning for exentration. I'm sure all the other colleagues, when they have their patients get teed up for exentration, they would like to do exploratory laparoscopy. We do laparoscopic assessments, cystoscopy, and peritoneal washing to make sure the patient doesn't have any positive cytology. We do excise single site recurrence and isolated tumor. We undertake in selected patients robotic or laparoscopic total exentration, very much similar to other centers in the world. And we do laparoscopic excision of pelvic and parietal lymph node for isolated disease. And on occasion, sadly, we have to do palliative diversion for disseminated disease, and the patients are presented quite late. And for cervical cancer, we also use minimal access surgery to treat precancerous changes, something that most of our colleagues who deal with the intermediate tumor, they deal with on a regular basis. For the pelvic exentration, we have a national guideline in the United Kingdom. We do, as part of our management and planning for exentration, we perform laparoscopic assessment. It's quite informative. We do this jointly with our colorectal colleague, urologist, to map and look for any peritoneal disease. As you know, laparoscopy has a CT scan and MRI has limitation in identification of peritoneal disease. Hence, it's quite important to add minimal access surgery as part of the planning. We follow our national guideline. British Society of Gynecologic Cancer has recommendations, which we heard the summary of these papers by Professor Hashemi as well and Professor Zodi earlier on. It's all summarized in these guidelines. We followed those guidelines. In this video I'm going to show you, not long ago we published this video of performing a laparoscopic upper corpuectomy on a patient which keeps coming back with the VIN3. And we all know that these patients can be treated by multiple treatment modalities, conservative management, or they could be treated by immune modulator or medication, but on occasion it's quite intractable, and you have multiple reports of severe dyskaryosis when these patients come with the recurrence of the VIN3. In this video, I'll show you how we perform upper corpuectomy for patients who have had total hysterectomy and have recurrence severe VIN. And as you can see, often these patients have a lot of follow-up, and the results are whatever you do is not good. And a lot of colleagues perform this by vaginal approach, or but we feel that the key thing is to be able to do this by laparoscopic assessment and also by laparoscopic approach. In this video, I'm showing you that the patient has had hysterectomy. We are opening the pelvic side wall, and identification of the ureter is quite important. Again, we have 8 avascular spaces in the pelvis. It's quite important for those spaces to be identified. We heard about Okabayashi, Latsko, and pararectal and paravaginal spaces, very known avascular spaces that is quite routine and accessed by our colleague who do gynecology oncology. Just before starting the surgery as such, it's very important to do another colposcopy and vaginoscopic assessment of the vagina. Try to mark the area which you think is the high-grade VIN. And in this case, the right vaginal fornix is the area which is affected by VIN. And what we do is we try to mark the vaginal in the first instance, and then apply the McCartney tube. Here you can see there's a McCartney tube in the vagina, trying to identify the area which have already flagged up by colposcopic assessment. And every now and then you need to fill up the bladder to be able to mark the bladder reflection and roll the bladder pillar and access to the upper vagina. And by doing so, you will be able to avoid some quite difficult medical treatment. For example, in UK, it's quite customary we use imiquimod or cidofovir. These medications are immune modulator. Some patients cannot tolerate them, for example. They will not be able to have or keep them for a long time. They often have to come back for multiple colposcopic assessment and a smear. So in this case, we're trying to tailor the surgery to what is needed. Remember, we don't want to excise too much of the vagina because sexual function is quite important. And at the same time, we want to balance this against the relapse and recurrence. Hence, we are mobilizing the bladder of the vagina by identification of the area which needs to be excised. The pelvic side wall is open. This is a rim of the McCartney tube. Size 35 millimeter has been used by reflection of the bladder. And then we're going to excise the area which we have identified vaginally. The right ureter has been identified. The main problem is on the right fornix. So we don't do as much as extension we need to do on the other side. This is a fine monopolar needle, which we use for colposcopy. It gives us a good chance to achieve good hemostasis and also very clean dissection. And we excise the vagina, which we have identified to have the VIN. These patients often have EUA and biopsies or mapping biopsies, we call it, prior to this excision. And we then excise this area in its entirety without compromising the sexual function or excising a large piece of the vagina, which often can be problematic later on. Often they're quite young and they keep coming back with the severe dyskaryosis needing treatment. So the upper colpuectomy is performed, and the area of VIN is excised, and this is delivered through the McCartney tube, which is our conduit without touching the vagina further. And then we close with number 1 monocryl, and it's a continuous closure. And we will pass the needle back to the vagina, and your cistern in the vagina will tie this, and the knot will stay in the vagina, as we do not want this monocryl to be sticking out in the vaginal vault and perhaps run the theoretical risk of fistula, especially when the small bowel attaches. So this is a very simple application of performing laparoscopy or minimal access surgery in the setting of precancerous cells. The next slide comes ovarian cancer. Probably after the publication of LAC trial, there are lots of focus now on treating patients perhaps with ovarian cancer. There are some prospective studies looking at the role of minimal access surgery in the management of ovarian cancer, either radical debulking or recurrence. But generally speaking, the patients who are chosen to have minimal access surgery in the ovarian cancer are the patients who have single site recurrence, who we are able to perform secondary cytoreductive surgery. That's very important. Often these patients need to have a laparoscopic assessment. And in ovarian cancer, we still do palliative diversion, and often we do concomitant pelvic, abdominal, or thoracic disease, which we then need to have a multidisciplinary approach to patients who meet the criteria for secondary cytoreductive surgery. We all are familiar with the paper published by Andrew Dubois from Essen, fantastic paper looking at prospectively of the role of secondary cytoreductive surgery in relapse. And we do have patients coming in who meet the criteria for these operations. Also, the other paper published in New England Journal of Medicine by Professor Coleman and Nick Spiritus, looking at the role of secondary cytoreductive surgery in ovarian cancer relapse. As you know, the patients who have had good outcome in the previous cytoreductive surgery, who we achieved no residual disease with a good performance status, the patient who also have no ascites, that you're confident that you can achieve no residual disease, these patients are recruited for cytoreductive surgery in the secondary setting. There is another paper which showed that the outcome of laparoscopy in the secondary surgical cytoreduction in patients with recurrent ovarian cancer versus minimal access surgery. Again, going back to my first slide, is quite important to try to perform these operations by minimal access surgery, as we have 2 randomized controlled trials supportive of doing these procedures, and also data on feasibility of doing this by minimal access route. One of the problem we have with the ovarian cancer, as we know, we miss the disseminated carcinomatosis. I'm not going to talk about radical surgery of ovarian cancer, which is my special interest in Oxford, but it's quite clear that a lot of patients who have disseminated carcinomatosis, minimal CT scan or MRI or even PET CT scan do miss the peritoneal disease, especially diaphragmatic disease, and also small bowel serosal disease. So it's quite a difficult task for the radiologist to be able to show us this kind of disease. This miliary disease often is not seen. Even if your CT scan showed that you have a single site recurrence, we still start our operation by minimal access approach, which is exploratory laparoscopy, peritoneal washing, and also map the disease. Very strict criteria we follow, make sure that we're not missing any cancer. This is another patient which we have not done not long ago, again published in JMIC. This is a lady that has had a relapse of ovarian cancer, not only in her abdomen and pelvis, but also in her chest. She's got a cardiophrenic lymph node that, again, she met the criteria, desktop 3 criteria, no ascites at presentation, good performance status and no residual disease. This is the third relapse she has come in. She's got a cardiophrenic lymph node that we have organized the surgery to be done jointly with our cardiothoracic surgeon. This is the beginning of the part of her surgery. She's having thoracoscopy, and we are excising the paracardiac nodule and part of her lung before we start the laparoscopy. This operation lasted just over 4 hours. This patient is a patient who then stayed in hospital for 3 days, and this lady had a BMI of nearly 40. So I think for us to be able to do this by open surgery, we would have subjected her to thoracotomy and large midline laparotomy. Thoracoscopy part was done successfully. It's very important when you invite your colleague who you don't operate regularly to make sure you have the right equipment, and they normally come with their own team, and we design the theater and patient positioning in a way that is appropriate. Now we have done the thoracotomy part. Now we're looking for the nodules which we have identified on the CT scan, doing the exploratory laparoscopy. LigaSure is one of our favorite instruments we use for coagulation, and also our other favorite instrument for dissection is a Schneider, which is a fantastic dissecting instrument used in action, and you can see we find those nodules, and one by one we excise that. So I think if your patient selection is correct, if you are fully aware of the available evidence, and for us now is desktop 3, and you're able to map the disease and follow the oncological hygiene, in this case, identification of these nodules and excising them, putting them in the bag. So while you're removing them through the port, they don't touch the conduit, which is your trocar. To avoid any dissemination is quite paramount, and it does help the outcome. And even for colleagues who do, for example, similar disease, you get to know what the gynecology team are capable of doing that, and often you get called to help them and organize joint cases which perhaps would have a better outcome as we are all becoming very specialized. And this is again a perfect example how the multidisciplinary approach to the patient's care is quite important. Through a very robust and strong governance, we can protect the patients and also perform evidence-based medicine, which is we did for this case. The other, the next slide is, again, is a surgery we have done not long ago, published in the Gynecology Oncology reports. This is a lady who has come in with the laparoscopy resection of the single site pelvic side wall recurrence 6 years after stage 3C high-grade serous primary peritoneal cancer. This is a lady, is 81 years of age. We performed her surgery in 2014. That was the first surgery. We achieved no residual disease. Then she comes back 5-6 years later with the enlarged left external iliac pelvic side wall relapse. With the rising CA125, she has severe kyphoscoliosis. We undertook her laparoscopy almost in a semi-sitting position, but we felt unbalanced. The fact that she was meeting the desktop 3 criteria sanctioned by Gynecology MDT in Oxford, we performed minimal access surgery for her. This is imaging showing the site of recurrence for this lady on the left pelvic side wall. And again, surgery starts by exploratory laparoscopy. We have not asked for much head down, as you can see, because patient will not be able to tolerate that. We often operate on a low pressure, and the pressure is normally 8, 9, or 10 to be able to have more head down if it's needed. Our approach is, as usual, is opening the pelvic side wall using bipolar scissor and Schneider for dissection. Identification of the key structures is quite important. Professor Hashemi talked about the boundary of lymphadenectomy. Those vital structures, including source and the vasculature of the pelvis, is quite important. In this case, we try to identify the vessels. This lady has had chemotherapy. she has had previous cytoreductive surgery, so the planes are slightly different. Remember, in this age group, the vessels go through atherosclerosis as well. So, and the anatomy change. Often they're L-shaped or S-shaped. They're not necessarily a straight. You need to be aware of the atheroma. You need to dissect around this tumor. Try not to cause any tumor spillage. So you don't have to just go straight on this mass. You need to excise a normal tissue around it to make sure that you do have clear margin also without a spillage. Often you mobilize a vessel from lateral to medial or medial to lateral, whatever you think is appropriate on the day. And then, of course, the development of obturator fossa, trying to identify the obturator nerve, and gradually identification of 8 avascular spaces in the pelvic sidewall, which is quite important. You constantly mindful of the patient's age and also communicate what you're doing with your anesthetist, because it's very important these ladies don't absorb too much CO2 given the age. And unlike a lot of cervical cancer patients who are young, remember a lot of ovarian cancer patients are quite old. Ureter needs to be identified. You then develop what used to be a pararectal space, the space between the ureter and the internal iliac artery, to be able to have gradual access to the main vasculature. So this approach is again facilitated by the dissecting forceps. And here is the Schneider, which is fantastic. We don't use irrigation. Our approach is a Sahara. So basically, we can use Mastostar for the lymphoria if it's forming, and work our way around the lymph node. On occasion, you would like to identify ureter better. You can sling the ureter and ask your assistant to give you a traction. Ureter is identified. Tumor distally might be very close to the ureter, so you can do that. And also you can sling this vasculature laparoscopically and be ready to clamp them if it's needed, especially given the patient's age. So we have already asked for those equipment to be available in theater while we're dissecting this relapse or nodal disease. And if you're in doubt, remember the paraphysical space is closed, bladder could be also closed. So it's quite important to feel the bladder if it's needed to identify the plane. We are now mobilizing this nodal relapse from the left pelvic side wall. And then we gradually moving from cranially to caudally or proximal to distal, but make sure that the main structures, including obturator nerve, lumbosacral trunk, if it's needed, to be identified and mobilized. And then when we are clear that there is no further disease there, here you can, if you want more traction or you're worried about any bleeding, before you clamp these vessels laparoscopically, you can even put the vessel loop and keep them in hand if it's needed, especially if you're in doubt about bleeding or you anticipate that there might be a problem. And then by these tractions, you will be able to do exactly what you normally do at laparotomy. At laparotomy, you would have probably identified the ureter by now and slung the ureter away. We do the same thing at laparoscopy, trying to maintain the traction because we want to minimize the complication that the patient might face at the time of his surgery. And the ureter now is slung away. We further dissect this tumor, make sure that the margins are clear, make sure there's no spillage. And by doing so, we're mindful of the other structures, and again, constantly aware of the length of the operation and how much this patient is able to put up with the long operation. You can see on the right-hand side, the ureter is under traction and the tumor gradually is mobilized. And again, distally is where you can see there's a fusion. This patient has had chemotherapy and these spaces have previously opened by us and the mass is excised. And they do ask me what happened if this patient bleeds. This is the application of Dubeki clamp before we start any pelvic sidewall dissection. If there's the Lear or anything, we will have them in theater. And again, putting the lymph node in the bag and close the bag before delivery, so you do not have any spillage. These handlings are gentle, and try to seal this off fully before delivery, and the clean wash and make sure the hemostasis is okay. And I do leave the drain after lymph node dissection or recurrence. Often these dissections are long, and this is not for hemostasis. This is to allow any lymphoria to come out for the next 24 hours. If you're worried about hemostasis, we never close anyway, so it's just for that. And this patient had a very swift recovery with no post-op complication and has not had relapse since then. So that was the end of my talk. Thank you very much.
Thank you very much for your nice and astonishing presentation and good dissection and accepting our invitation.
Absolute pleasure. Thank you very much.
Thank you. The next lecture is from Dr. Shailesh. Can you hear me?
Yeah, I can hear you.
Yes, Dr. Shailesh Puntan-Bekar is the Associate Professor, Oncologic Surgeon and Consultant, Chief Medical Director, Galaxy Care Laparoscopy Institute, India. We are ready to hear your lecture about laparoscopy in ovarian cancer.
Okay, thank you very much for the invitation. Now, the previous speaker has to stop sharing his screen.
I've done it.
Okay, thank you.
My apologies, yes.
No problem. So we will have this role of laparoscopy in ovarian cancer. This is one topic which I have been very passionate about, and thank you for the opportunity. It's a great pleasure to be there. I have been to Tehran to operate, and it's always a pleasure to be with the Iranian Society. So thank you very much for the invitation. Hello, Tehran. And this is the Oncology Gynecological Conference. I'm not going to go much into the theoretical aspect because everybody knows about it. There is epithelial tumors, stromal tumors, germ cell tumors, and of course the risk factors. These are, because this is one of the leading cancers of women. 90% of the tumors are epithelial tumors, and I would be considering myself only to speak on epithelial tumors because germ cell tumors and granulosa cell tumors can be easily tackled laparoscopically, and there is not much discussion regarding those tumors. 75% of the patient present in stage 3 or stage 4, and that is the biggest problem that we face all over the world. And this is the survival. We all know that the survival is directly related to the surgical staging as well as the amount and good surgery, which is very, very important. Diagnosis mainly by the CECT as well as the tumor markers, and management is of course the most important aspect, which is what we are going to deal with today. It is the complete surgical staging, optimal cytoreductive surgery, and of course chemotherapy. So what is the role of laparoscopy in ovarian cancer? There is a role for laparoscopy, as initially people thought it would be only for second look. Things are becoming a little bit different now. We are doing it after the neoadjuvant chemotherapy, as well as in various regions where we can use. More recent instrumentation with modern endoscopic instrumentation techniques, extensive cytoreductive surgery can be associated with good laparoscopic surgeons, especially if the patient is having tumors which are limited to the pouch of Douglas after chemotherapy. So we do exentration, large and small bowel resections, diaphragmatic stripping, splenectomy, and of course, para-aortic lymphadenectomy. So these procedures are technically challenging, but these can be converted by laparoscopy. It all depends on your experience of dealing with it. The basic aim of laparoscopy remains the same, that is the optimal debulking. And that is the most important thing that we have to do. What is the role of laparoscopy in ovarian cancer in the early stage? Of course, when you have masses of undeterminate origin, then for evaluation, diagnosis, and staging for an adnexal mass, when you want to do a frozen section, it would be better if there is a mass which is limited to one ovary. You can do the evaluation, diagnosis, and staging in the early cancer. The role of laparoscopy in ovarian cancer in the advanced stages, the biggest question that is asked to us is, do you really do primary debulking? And the answer to this is no. We don't do primary debulking because majority of the patients present to us in stage 3. Yes, But there is a definite role of laparoscopy in interval debulking after NACT, that is neoadjuvant chemotherapy. There are multiple trials which have taken place, and you can do same kind of debulking after 3 or 4 cycles of anterior chemotherapy. Also, in patients in whom CA125 is rising, while rest of the reports are normal, what we used to call it as second look laparotomy, the same thing can be done with laparoscopy, which is called as second look laparoscopy, and of course, cytoreduction of the recurrent cancers. The biggest concern is whether you are doing it accurately, whether there is a risk of dissemination, port site metastasis, which is the biggest problem that people keep on asking. But in the largest trials, even with port site metastasis, with cisplatinum-based therapy, it is not affecting the survival. So role of laparoscopy in the early stage, if it is a small tumor, you can do a laparoscopic bilateral or unilateral salping oophorectomy, ascitic fluid cytology, peritoneal biopsy, if required, a total laparoscopic hysterectomy if frozen section is positive, omentectomy, and of course pelvic and para-aortic lymph node dissection. Why? In early stage, there are similar rates of recurrence after laparoscopy as well as open staging procedure, as long as the tumor is in the stage 1 or limited to the pelvis and there are no peritoneal deposits. If there are peritoneal deposits or deposits in the subdiaphragmatic area, it is not worth doing the laparoscopy. You have to continue either with the open surgery. So the message is very clear. Only for the tumors which are limited to the adnexa, you can go ahead and do this in the early stages. In stage 2 and 3, optimal debulking following NACT, that is post-cytoreductive chemotherapy. After doing a chemotherapy, you can do this, and of course the second look laparotomy. Now, optimal cytoreduction is something which we all of us know, that it has to be tumor which is less than 1 centimeter residual tumor. The question is, can this be achieved? Of course, it can be achieved. The same kind of thing that we do with open surgery, we can achieve this with pelvic lymph node dissection, intracoelic para-aortic dissection, and of course, appendicectomy and anterior and total pelvic node removal. What is the advantage of doing it? In selected patients, the biggest advantage is that the less morbidity, shorter operative time, but the most important thing is early application of adjuvant therapy. That is, after giving 3 cycles of chemotherapy, if you do laparoscopic surgery, you can give the 4th cycle within 10 days, which doesn't happen after a laparotomy. So post-chemo, definite role and need of laparotomy is completely avoided. Isolated recurrence, lack of ascites, and of course, optimal debulking as the primary surgery are the indications for secondary debulking. So we have these chart, you all know about it, that in stage 3 and 4, you can use it as a diagnostic tool and to assess the operability and do some kind of frozen section and then give chemotherapy and do secondary debulking. Or after neoadjuvant chemotherapy, you can do interval debulking with the laparoscopy. Everything has to be removed in the endobag. Aspiration of the cyst also should be done in endobag, and removal of the masses also should be done in the endobag. So this is the kind of endobag that we do in our place. We put this in endobag. This is a simple glow bag that we use, and we put everything in the endobag before we take out. What about inoperable cancer ovary? In inoperable cancer ovary, of course, you give neoadjuvant chemotherapy, but at least you can diagnose and, of course, do chemotherapy followed by surgery. The neoadjuvant chemotherapy, of course, has some kind of disadvantages. I'm not going to go into the various details because EAG trials have already proven that surgery is the best modality, but majority of the patients present to us in stage 3C and stage 4, it's not worth doing and we do not achieve optimal debulking. What is the indication for early ovarian cancer? For accurate staging, we can use this, and with low risk disease, it can be also used to do lymph node as well as para-aortic lymph node dissection. Patients with intermediate or high risk, you can have tumor size which are less than 2 centimeters, grading less than 3 centimeters, and myometrial invasion, which is more than 50%, you can do para-aortic lymph node area. So laparoscopic lymphadenectomy, of course, it is possible. Previous speakers and everybody has showed you But I am going to show you, this was a patient in whom after giving chemotherapy, there were just nodes which were limited to the area, and we could easily do an ileo-obturator nodal dissection, which is very, very easy. Just for doing this nodal dissection, you can see the CA-125 was rising because of these nodes, and these nodes could easily be taken out after doing full cycles of chemotherapy. Before that, they had undergone the debulking in the open surgery, but we could do this laparoscopically, and you can see that all the nodes can be clinically completely removed. That's the obturator nerve, and all the ileo-obturator nodal dissection, we could take it out. What about the role of para-aortic dissection? The para-aortic node dissection can be easily done. Either we do a para-aortic node dissection trans-peritoneally, but we don't, this is the trans-peritoneal nodal dissection that we do, and I'm going to show you a little bit. This is the duodenum, and this was a patient in whom there were large para-aortic nodes following the chemotherapy. So we take these two sutures and hitch up the duodenum. This is the trans-peritoneal approach. You can go right up to the renal vein, that is the left renal vein. You can see that, and all the nodes along this area. So these are the nodes. You can see all the nodes, big nodes, which can be taken out along the inferior vena cava, along the aorta, interaortocaval nodes, and all these nodes very easily could be taken out completely laparoscopically. So we use two approaches. This is what you can see, the complete aorta, complete inferior vena cava, which is completely cleared, and then we keep on clearing even the para-aortic region. So this is one of the very good things to do. Previously, the morbidity associated with para-aortic nodes was very high, but with laparoscopic, this is, you can see the nodes which are very, very big, and they were following complete chemotherapy, and these nodes could be easily taken out. You can see the complete removal, and then this is the external iliac artery and the vein which we go down further, and this is the left renal vein. You can see the nodes right up to the left renal vein be completely cleared. Now this approach is a very good approach, especially if the patient has received complete chemotherapy, and this approach can be used even in the patients in whom previously laparotomy has been done. So you can see all the nodes cleared. This is all the aorta and the inferior vena cava completely cleared. Each and every node taken out. Even the interaortocaval nodes are taken out, and they can be a very good dissection which is done. Otherwise, we basically prefer to do extraperitoneal. The reason for doing extraperitoneal para-aortic node dissection is because it is much easier to do this. The retraction is very less, and you can easily do this extraperitoneal. You can see this is the psoas muscle which is here, and then you go and reach up to the aorta. You can see the ureter at the roof. This is and now you can go underneath the peritoneum right up to the inferior vena cava. So you can see that extraperitoneal nodal dissection, you don't require much amount of retraction. It is a much easier thing. This is the superior hypogastric plexus that you are seeing. You can see the ureter and the superior hypogastric plexus remain at the roof, and all the nodes along the aorta. This is the para-aortic region. This is, you are going right up to the vena cava and also up to the left renal vein. You go underneath the superior hypogastric plexus, and all the nodes along the aorta can be easily cleared. So this is a chain of para-aortic nodes, and these nodes can be easily cleared. You can see all these nodes being taken out over here. And once you take out all the nodes from there, this you can see go underneath the area, big nodes, and these nodal dissection can be easily done with an extraperitoneal nodal dissection. So you can see all the nodes being cleared along the aorta, all these big nodes which are post chemotherapy. They are not easy to tackle with, but you can do a very good clearance. You can see the external iliac, the common iliac artery coming into the picture, and now you can see the complete aorta lower down. You can see the hypogastric plexus. You can see how the entire aorta is completely bared, and you can go just even to the right of the aorta, go up to the inferior vena cava and take out all the interaortocaval nodes also. So extraperitoneal approach is a much better approach. You can see that. That's the inferior vena cava over there. And all these nodes can be easily taken out with the extraperitoneal para-aortic node dissection. These are the lumbar arteries and the vein. You can go underneath the aorta, take out all the nodes along the underneath the aorta. A complete clearance can be easily achieved using extraperitoneal nodal dissection, and the ureter and the entire hypogastric plexus always remains at the roof. You can see a simple bipolar can be used to clear all the nodes in the interaortocaval region. This is the interaortocaval region that we are trying to take out all the nodes along this area. So this is how the entire picture looks like at the end of the dissection. You can see a complete superior hypogastric plexus, post-ganglionic sympathetic fibers, and then you can go down and even clear the external iliac nodes along the external iliac artery and the external and the common iliac vein. All these nodal areas can be easily cleared by doing extraperitoneal lymphadenectomy. What about the diaphragmatic stripping? This is very easily done. This is a simple operation to do infracolic omentectomy. This can be done if the patient was accidentally diagnosed with the ovarian epithelial cancer, referred to us after the laparoscopic removal of the adnexal mass. There was no spread anywhere. All we had to do was a complete omentectomy. You could see that this is a very nice infracolic omentectomy. You can fill it in a bag. Then, of course, you do an appendicectomy along this area. This is important that you do the same kind of dissection that you would do. And this is the appendectomy. And once the appendectomy is done, then you can go ahead and do even subdiaphragmatic stripping. So all this can be easily done laparoscopically. You can see the subdiaphragmatic stripping being done. Fairly simple procedure. Imagine this procedure to be done with a big laparotomy. This is very easy to do and very easy. The entire peritoneum can be stripped off and can be sent for histopathological examination with a very good optimal debulking. What about exentrations? You can do various kinds of exentrations. So this is another patient in whom there was an ovarian cancer, and this ovarian cancer was treated with chemotherapy. And with this chemotherapy, the tumor still remained over there. And this was involving the bladder anteriorly. So we did a complete anterior exentration. You can see opening of the cave of Retzius remaining medial to the internal iliac artery, a complete removal of the bladder. This is the exposure of the pubic bone. Because of the want of time, I'm just showing you the glimpses of what can be achieved. This is a complete anterior exentration. You can see the Foley's catheter over there. And then the ureters, they were clipped. The entire nodal dissection was done in the same way that I have showed you. These ureters were clipped and the entire nodes you can see being removed from this area. All these nodes were taken out, and this is the same kind of dissection you would do along the vein when you do an open surgery. So you can see in this patient, we did an ileal conduit because the urinary diversion has to be ileal conduit, and these two ureters were then taken out and they were attached to the entire bowel, and an ileal conduit was also performed in this patient. So this is how we can do an intracorporeal ileal conduit. I'll not take much into the details, but then the biggest, the surgery that is very commonly done for ovarian cancer is a posterior exentration. These are the patients who do not respond very well, and they continue to have the deposits in the pouch of Douglas. So you can see there was the deposits in the pouch of Douglas. The ureter is separated out. That's the uterine artery. This is the paravesical space that we have opened out. And once we have opened out the paravesical spaces, then the ureter is completely mobilized because we are going to save the bladder. A similar dissection on this side. And finally, we realize this is the dissection. Now we are going to go into the presacral region because this is a posterior exentration. You can see a removal of the rectum from behind. This is the presacral area. That is the middle rectal artery that we have taken out. We are going to take out and mobilize. This is a complete dissection that we do of the rectum along with the uterus. And once this is done, then we take the inferior mesenteric artery and the vein. We are clipping the inferior mesenteric artery and the vein. And then this is the rectum that we are stapling. This is the same kind of thing that we are doing after the even after endometriotic surgery, and then we rejoin this. So this is the posterior exentration, which can also be achieved laparoscopically. So a lot of things can be done in ovarian cancers, and this is a nodal dissection which I will not take you. So this is what is our experience, role of anterior exentration in advanced and recurrent tumors, published in the Journal of Pelvic Surgery way back in 2002. And then we have published the largest experience of robotic anterior pelvic exentration for ovarian cancer and laparoscopic posterior exentration in advanced gynecological malignancy in the JMIG. So all these are there. Our exentration, this remains as the largest series with 85 patients which have been published. So the biggest question is laparoscopic pelvic exentration for gynecological malignancy. This is a paper which has been published, and it clearly shows that laparoscopic posterior exentration is feasible and a curative intent to selected patients. Potential post-operative advantages are being that the morbidity and mortality is low. So in ovarian cancers, if you have the skills and if you have a tumor which is limited in the pouch of Douglas, this can be easily done. The biggest thing that you have to prevent is when you resect the tumors, you have to prevent rupture, minimal tumor manipulation, use of endobag, and of course, avoid carbon dioxide leak and sudden desufflation. Port site metastasis, yes, these are common. We get about 5 to 10% of the patients who get port site metastasis in our series of 85 patients of exentration. You can go through this. In JMIC, this is the largest series published for posterior exentration for ovarian cancers. You will find that we had 10% of the patients with port site metastasis, but there are certain things you can do to prevent this. Removal of the abdominal fluid before removal of the trocar, exfoliation of the peritoneal cavity, and irrigation of the port site after the removal. This is the best way to prevent this. So this is a kind of port site metastasis that we had in our series, and these port site metastasis could be easily taken care by doing the chemotherapy, and this did not affect the overall survival, which has been reported in majority of the series. Lastly, can we do HIPEC? Of course, HIPEC is the biggest advantage when you do it laparoscopically. That is the hyperthermic. You can do intraperitoneal chemotherapy, use of laparoscopy for staging, and use of laparoscopy for HIPEC. This is one of the biggest things. You have to do a complete peritonectomy, and following which you can do HIPEC using this. So HIPEC is very easily achievable. This is one of the biggest advantage. We know that 30% survival increase with HIPEC. You don't have to do an open surgery. This can be done laparoscopically. So in conclusions, laparoscopy can be used at various stages. It all depends on your ability to do these surgeries. Frozen section is very much necessary. It is very important to keep your ego aside. Optimal debulking should be done. If not possible, there is an option of opening it. But the most important thing is, in a country like ours, in about 10 to 15% of the patient with disseminated disease presented to us with CM124 of 350, we have found about 30 or 40 patients of tuberculosis when they were actually diagnosed as ovarian cancer. And when we did it laparoscopically, these patients would have unnecessarily undergone laparotomy. So assessment, diagnosis can be easily done laparoscopically. This is the book in which you can go through this. This is a book which is published by us. And of course, there are no limits to what you can do, accomplish, except that you have to should not put the limit on your own thinking. And this is the most important job. We are proud to announce that we were the first laparoscopic retrieval of donor uterine transplant that we did way back in 2018. And this lady delivered a child. This was the first laparoscopic donor retrieval in the world. So we are proud. This was a team of doctors who did this. And this is Meet India's first transplant team. And this is the baby who was born after the uterine transplant. So we are proud that we are all continuing our journey with minimal access surgery, be it laparoscopy in ovarian cancers, be in cancer cervix, or in uterine transplant. Again, I take this opportunity to thank you, the Iranian Society, to give me this opportunity to talk on a topic which is so vast. To cover it in 20 minutes is next to impossible, but I have tried my level best to tell you what is the role. then you can go through your thinking. Not everything can be told in one lecture. So thank you very much, madam. It's a great pleasure to be on this show. Thank you.
Thank you very much from your nice presentation, and the uterine transplantation was astonishing. Thank you very much.
Thank you.
The last lecture is from Dr. Razia Sadat Hashemi, Assistant Professor of Gynecology and Oncology and Laparoscopy, Radicality University of Medical Science of Iran. The base of a good surgery, especially a successful oncologic surgery, is anatomy. And the anatomy is the last but not least important lecture in our webinar. Dr. Hashemi is my teacher in knowledge and ethics. Dr. Hashemi, can you hear me? Dr. Hashemi, we are waiting for your lecture.
Hello. I greatly appreciate webinar organizer, especially my dear friend, Professor Rehan Hosseini. And I hope all of participants will be good and healthy. Are you seeing my slide?
Yes, but not in full screen show.
Yes. Is it okay?
Yes, it's okay.
In the name of Allah, my lecture is about pelvic anatomy and spaces. I try to answer 3 questions: how to enter retroperitoneum, how to find ureter, and how to open avascular spaces of pelvic. First, I briefly explain abdominal wall. Intraperitoneal view of anterior abdominal wall demonstrated 5 peritoneal folds during laparoscopy. And these ligaments can be seen well during laparoscopy, and they are important marker for surgery. The first ligament is median umbilical ligament or remnant of urachus. The second are 2 medial umbilical ligament or obliterated umbilical arteries. And the last 2 lateral umbilical ligament or peritoneal fold covering inferior epigastric vessel.
Median umbilical ligament or urachus is a marker for entering reduced space. Medial umbilical ligament or obliterated umbilical artery, we can use this for entry paraphysical space. Lateral umbilical ligament or inferior epigastric vessels, we must be careful not injure them during trocar entry.
The second question is how to enter the retroperitoneal area. When there is a distorted anatomy of peritoneal structures, to achieve a normal anatomy and resect all pathologic lesions, the surgeon needs to gain access to the retroperitoneum, which is mainly safe, and that leads to a comprehensive dissection and visualization of the relevant anatomy. An easy way to enter the retroperitoneum is the peritoneal reflection between the round ligament and infundibular ligament. After transecting the long round ligament by cutting the posterior leaf of the broad ligament, pararectal space is developed. And after cutting the anterior leaf of broad ligament, the paraphysical space is developed.
How to enter retroperitoneal space. This is left round ligament. By transecting the round ligament, we can enter the retroperitoneal area. The peritoneal reflection between the round ligament laterally and infundibulopelvic ligament medially is cut. We should continue parallel to infundibulopelvic ligament. Gentle traction on the lateral peritoneum is very helpful. You can see left external iliac artery and lateral to external iliac. You can see psoas muscle. By gentle traction of infundibulopelvic, medial and cephalad, we can visualize ureter easily. When we open retroperitoneal space such as this video, ureter is located under and lateral to infundibulopelvic ligament.
Another question is how to find ureters. We can find ureter transperitoneal without opening the retroperitoneum, but it is difficult in obese patients, in adhesions, and in endometriosis. We can find ureters retroperitoneally by opening retroperitoneum at pelvic rim. We can find ureter, or by opening retroperitoneum lateral to infundibulopelvic ligament, such as previous video. When the ureter enters the pelvis, it runs inferior to ovarian vessels on the posterior leaf of the broad ligament. It goes anteromedially while crossing the uterine artery, water under the bridge. Afterwards, it enters the ureteric tunnel or web tunnel between the cardinal ligament and passes lateral to the anterolateral vaginal fornix between the bladder pillars and enters the trigone of the bladder. You can see in this video transperitoneal finding the ureter. Sorry, there is a problem.
In this obese patient, transperitoneal visualization of ureter is difficult. After cutting round ligament and transecting peritoneum parallel to infundibulopelvic and upward and medial traction of infundibulopelvic, we can find ureter under and lateral to the infundibulopelvic ligament.
Avascular spaces of pelvis. These spaces are filled by fatty or loose areolar tissue, which are generally avascular. These potential spaces have a role in the function of urinary, reproductive, and GI system. They have a crucial role in the management of pelvic operation, especially in gynecology, oncology operation, because knowledge of them exactly allows restoration of normal anatomy and avoid injury of pelvic viscera and structures. These pelvic spaces are 6 spaces: midline spaces, are 4 space, retropubic or retzius, perisacral, physicovaginal, and rectovaginal space. And lateral spaces are 2 paired spaces, pararectal and paraphysical spaces. You can see this picture in midline for avascular spaces, and in lateral 2 paired avascular spaces. First, I explain retzius space. It is a potential extraperitoneal space between the bladder posteriorly and pubic bone anteriorly. Its boundaries are anterior pubic symphysis, posterior bladder, superiorly parietal peritoneum, laterally arcus tendinous. How to enter retzius space in laparoscopy? By grasping the median umbilical ligament or urachus above the bladder and downward traction and cutting it, we can open this space. This space used mainly in birth corpus suspension. We should be cautious about structures lateral to the bladder, neck, and urethra. They are nerve and venous plexus. Venous plexus or Santorini plexus, this could be injured during suture placement for birth corpus suspension. This video is about entering to retzius space during laparoscopy.
How to enter retzius space. By grasping the urachus ligament above the bladder and downward traction and cutting the urachus ligament, we can open retzius space. Continue dissection under rectus muscle sheath. Paravesical fat should be pushed downward. When pubic bone or symphysis pubis is visualized, the section continued near to the bone.
The other space is vesicovaginal space. Vesicovaginal space is anteriorly related to trigon of bladder, posteriorly posterior of this space is vagina, and laterally is bladder pillars, and inferiorly urogenital diaphragms. The lateral bladder pillars contain blood vessels, vesical veins, cervical terminal branches from the uterine artery, and connective tissue from the cardinal ligament. During radical hysterectomy, before excising the anterior parametrium, the bladder should be dissected to the level of the trigon. Vesicovaginal space dissection should be performed medially at the midline within the loose areolar tissue because lateral extensions during dissection could cause bleeding from the bladder pillars. How to enter vesicovaginal space? By grasping and transecting peritoneal reflection between uterus and bladder and traction of uterus toward the promontorium, we can enter vesicovaginal space.
How to enter vesicovaginal space. Peritoneum between two round ligaments exposed. Vesicouterine peritoneal reflection incised. It can be sharply or with electrocautery. After that, the bladder is mobilized inferiorly away from the cervix. Boundary of vesicovaginal space are shown. Laterally, vesicouterine ligaments, anteriorly bladder and posteriorly vagina.
The Yabuki space or fourth space is a midline small retroperitoneal space. It is between lateral aspect of uterine cervix and deep layer of vesicovaginal ligament. It confined between the anterior surface of uterus and the ureter inserting into the bladder. This space is lined by the cervical vesical fascia and contains parasympathetic nerve innervating the bladder. Careful dissection at this space help in nerve-sparing radical hysterectomy and protect distal part of the ureter.
The Yabuki space is a fascial cleft between lateral aspect of the uterine cervix and deep layer of vesicovaginal ligament. By dissecting this space, distal part of ureter, when inserting into the bladder, is visualized. Development of this space allows to dissect and helps to protect the distal part of ureter during radical hysterectomy when uterus is removed with upper part of vagina.
A presacral space is a small retroperitoneal space behind the rectum. This space is anterior of this space is rectum, and posterior of this space is vulvar fascia. The presacral vein is lying posterior to the vulvar fascia, and it is important to be careful when dissect this space because we should not injure presacral veins. The retrorectal or presacral space is useful in posterior exentration when rectum is involved, for DIE surgery, for sacrocolpopexy, and for presacral lorectomy.
For entering presacral space, peritoneum overlying the sacral promontory, medial to right ureter, and medial to right common iliac artery is transected. Upward traction of peritoneum protects injuring to underlying vessels. In presacral space, you can see common iliac artery and veins, middle sacral vessels, ureters laterally, and the hypogastric nerve plexus.
The other space is rectovaginal space. The rectovaginal space is from the rectouterine peritoneal fold or pouch of Douglas to the level of the preanal body. Access to this area can be maintained by cutting the rectouterine peritoneal structure between the insertion of the uterosacral ligament, which is bilateral. Its boundaries of recto-vaginal space are anteriorly posterior wall of the vagina, posteriorly anterior wall of the rectum, and laterally uterosacral ligament or rectal pillars. The rectovaginal pouch will be enclosed by severe adhesion due endometriosis, tumor, or abscess. The loose areolar tissue between the rectum and vagina can be bluntly dissected easily. However, we should be cautioned that the fatty tissue in this area belong to the rectum. The rectal pillars are fibroconnective tissues which are vascularized by the middle rectal arteries from the internal iliac artery over the cardinal ligament.
How to open rectovaginal space. Lateral boundaries of rectovaginal space are uterosacral ligaments. We can enter rectovaginal space by cutting the recto-uterine peritoneum between insertion of uterosacral ligaments bilaterally. After cutting peritoneum, the loose areolar tissue dissected. Fatty tissue in this area belong to rectum and should be pushed downward.
Another space is paraphysical space. The paraphysical space is located within the lateral part of radius space and anterior to cardinal ligament and anterior to uterine artery. Boundaries of paraphysical space are medially bladder pillars, laterally pelvic side wall, and obturator internus and levator ani muscle, superiorly lateral umbilical fold, inferiorly pubocervical fascia, and anteriorly superior pubic ramus, and posteriorly endopelvic fascia. Paraphysical space contain obliterated umbilical artery, obturator neuromuscular bundle, and external iliac vessel with the lymphatic and fatty tissue. How to enter paraphysical space? After opening the retroperitoneal space by transecting the round ligament and cutting the anterior leaf of broad ligament inframedially, the place lateral to the median umbilical ligament, medial to round ligament, adjacent to the bladder is the paraphysical space, and it develops inferiorly to the level of levator ani muscle. Lateral to the median umbilical ligament, after detecting the lateral border of bladder, the medial umbilical ligament or obliterated umbilical artery can be identified, and it divides the paraphysical space into two parts, medial and lateral. The lateral part is the obturator space under the external iliac vessels, and the medial part is the ventral parametrium. The obturator space contains obturator nerve, obturator artery and vein, and fatty and lymphatic tissue. This space is generally accessed during birth, pelvic lymph node dissection, some endometriosis operation, and radical hysterectomy. You can see in this video paraphysical space.
How to enter paraphysical space. vascular bundles, and lymph nodes.
The last space is pararectal space. The pararectal space is located lateral to the rectum and lateral to retrorectal space, and it is at the posterior part of the cardinal ligament and posterior of uterine artery. Boundaries of pararectal space are anteriorly cardinal ligament, medially rectal pillars or uterosacral ligament, laterally internal iliac artery, posteriorly sacrum, and caudally puborectalis muscle. Pararectal space contains fatty and connective tissue, and ureter will divide pararectal space into two parts. Medial is Okabayashi space and lateral is Latsko space. Okabayashi space or medial pararectal space, it is between the ureter medially and the rectouterine ligament. Between the ureter laterally and the rectouterine ligament, which is developed after opening the posterior leaf of the broad ligament. The Okabayashi space contains nerve fibers of the superior hypogastric plexus. It holds clinical and surgical significance for nerve-sparing radical hysterectomy, as well for nerve-sparing fertility preservation procedure in endometriosis. Latsko space or lateral pararectal space between the ureter medially and pelvic sidewall laterally, and developed after dissection of internal iliac artery. When pouch of Douglas is obliterated by a tumor, severe adhesions or endometriosis, the surgeon should primarily open the retroperitoneal space, find the ureter, and after ureterolysis, the pararectal space should be developed to dissect the rectum from the vagina and open the rectovaginal space. During radical hysterectomy, the pararectal space should be developed to excise the cardinal ligament entirely. After dissection of the posterior leaf of the broad ligament posteromedially, the pararectal space is developed between the ureter and internal iliac artery anterior to the sacrum. This video is about pararectal space.
How to enter pararectal space. After cutting the round ligament and opening the retroperitoneum parallel to infundibulopelvic ligament and finding ureter, pararectal space is developed. After finding ureter, dissection should be lateral to ureter for finding internal iliac artery and uterine artery, and to develop Latsko space or lateral pararectal space. Dissection medial and parallel to ureter leads to development of Okabayashi space or medial pararectal space. Uterine artery is the anterior boundary of pararectal space and posterior boundary of paraphysical artery. Continuation of dissection anterior to uterine artery leads to development of paraphysical space and finding obturator nerve and obturator fossa and visualization of lateral and medial paraphysical space.
Thank you for your attention.
Thank you very much for your kind acceptance and very nice presentation.
Thank you.
Do we have any question from audience?
No.
Thank you very much for your attendance and your patience and joining us. I hope to see you again in future webinars. Everyone, please turn on your video, and we have a photograph for memories. Ms. Alaeddini, can we have photograph?
Yes, doctor, we are taking a lot of screenshots. Thank you all for staying with us. It was a great session today. Thank you all.
Thank you, Dr. Azadi again
Thank you
for
very much.
joining us.
Thank you. My pleasure.
Thank you.